And wait for 2-3 minutes.
I think Dr. Ashok would.
Ashok sir also will join in between if available. Okay.
Yeah. I think Dr. Usha, can you please stop sharing? I think the final CV slides are with with Nilima, so she'll share that.
Okay, yeah, madam.
So please
I will
stop share. Yes. Nilima, you have the final, no?
Yes.
Yes, please share that. Yes. So I think, should I call madam? She was there, Sheila madam.
Yes, madam is there. Madam will join.
Yes, madam. Yes, madam. I think in interest of time, it's good to start the program. So today, welcome you all to this Foxy ICUG certificate course on oncology for the 3 days. It has been a very well-crafted program for the 3 days. This is the second day. So 27th is specifically an ovary, and I am your convener for today, Dr. Bhagyalakshmi Nayak. And I have with me, so I work as a professor in the Department of Gynec Oncology. So we will have with us Dr. Ashok Kumar. Please go ahead. And I think sir will be joining us very shortly, ICUG Vice Chairperson. And ICUG Chairperson elect, we have with us Dr. Sheila Mane. So we are really privileged to have Dr. Sheila Mane madam with us. So she is the ICUG Chairperson elect for 2025.
Bhagya will proceed.
Yes, madam.
Yeah.
Most welcome.
Yeah. So congratulations to all of you, yourself, Dr. Sarita, as well as Dr. Harshad Parasnis. I think, yes, as you rightly said, it's a very well-structured program. And you are covering 3 major malignancies, okay? So,
yes,
I mean, everybody is getting so much of rich knowledge sitting at home across their phone or their system, which is very good. And I know that how hard you people are working, and your expertise also, I know, in these subjects. So, hearty congratulations. And also, the coordinators are also doing a good job. So, I wish all the best for this webinar. And I know this is the last certification course of this year. Every month we are doing one, and looking forward to do again the repetition and the revision of with the newer things as the new things keep developing during my tenure also, Dr. Bhagyalakshmi, Dr. Sarita, as well as Dr. Harshad Parasnis, because it is the need of the hour, I think, where we'll have to, do this. And this is a real privilege to all our members that this certification course is helping them to know so much about all the newer things. So thank you for giving me this opportunity, and best of luck. Thank you.
Thank you so much, madam. Thank you so much. So I think the next on agenda would be, yes. Yeah, so I think already we have heard about what madam has spoken about oncology. So today's program is specifically crafted to deal with ovarian cancers, and especially how to deal them if you are not an oncologist or you are an oncologist. So it's a day-to-day practice that we come across adnexal masses many times, and there are 1,000 queries about how to diagnose them, how to manage them, when to refer to any oncologist, whether she will need chemotherapy or not, what are the terminologies used, what is the imaging that should be taken, first taken, and if you get an ultrasound suspicious, what should you do then, what are the role of tumor markers. I think there are so many things to discuss. It could take, I think, 2 days, but still within this 3 hours, we have tried to cover and curated a program that would actually address most of the queries that come across in your day-to-day daily practice. So in case you have your questions, please don't hesitate to put them up on the chat box, and we have specifically kept some time to address all your questions. And in case it's not possible to do it verbally, I think we'll request all the speakers to put them on the chat box, the answers. And second is that we have so eminent speakers who have been chosen and picked from throughout India and who are the best in their specialties. And I think again I have to acknowledge and thank the role of the chairpersons who are also more knowledgeable and will add to all the scientific discussions that are going to happen in the next 3 hours. So thank you very much. And I think sit back and enjoy each and every lecture, which is actually going to be a class apart. Thank you so much. And I think I have to thank Usha Shri, my coordinator, who has been done a great work for this 3 hours program. And I think, yeah, so she's Dr. Usha Shri Das. So she's working as assistant professor in Department of Gynec Oncology at AHPGSC Cuttack. And then before I end, I think I'll have to tell you about the post-test MCQ that will happen at the end of the session. So attendance for all 3 days course is compulsory. Google link for the MCQ will be sent in the chat box at the end of the 3 sessions. And those who have attended all 3 days course and pass with 50% marks on each day, they only get the certificate from ICUG, and that's very, very important. So be very mindful during the lectures so that you are able to answer most of the questions. And certificates will be sent within 1 month. And please note that this online course certificate is just an acknowledgement of attendance. But I actually have to vouch that it will surely improve your skills in practice. So practice depends on skill and experience, which we do not certify though. But then you will surely gain so many practicing points from all these talks. So we do not endorse any skills of the attendees. The videos will be put on ICUG website in due course. For course material and equipment details, you may communicate with the course coordinators. So thank you very much. And I hand over to the coordinator, Dr. Usha Shri, to actually carry it forward from now. Thank you so much.
Thank you, ma'am. Thank you so much. So without further delay, our first session is on diagnostic dilemmas in ovarian cancer, and the chairperson for the same are Dr. S.K. Giri, sir. He is the ex-professor of Acharya Hariyar Cancer Institute, Cuttack, and also my teacher. And the next chairperson is Jeeta Parija, madam. Next slide, please.
Yeah, I think it's visible. So she is professor and
HOD of Gynec Oncology. Previously, she was HOD of Gynec Oncology in Acharya Hariyar Medical College. Now she is Professor HOD in some medical college and hospital, Bhubaneswar. And the third chairperson for the session is Dr. Sujata Mishra, ma'am. She is Professor of OBGY in Postgraduate Institute of Medical Science, Bhubaneswar. And the first talk in this session is the red flags when to suspect ovarian cancer. The speaker for this session for this talk is Rohini Kulkarni, Dr. Rohini Kulkarni. She is Associate Professor in Department of Gynec Oncology, Tata Memorial Center, Mumbai. Madam.
Hello. Yeah, thank you for this opportunity and inviting me to be a speaker in this esteemed conference. So can I have the slide sharing rights, please? Yeah, I do.
Yes, ma'am.
Thank you. Thank you. Just 1 second. Is anything visible?
Yes, it is. You have to make it full screen only.
Yes, 1 second. Is it full screen now?
Yes, ma'am.
Yes, perfect.
Yeah. So today my topic would be red flags when to suspect ovarian cancer. And this is quite a dilemma, as you can see in this picture, where this woman who is completely emaciated with a bulging tummy and some amount of pain is wondering what she has. So ovarian cancer is a silent killer, not because it lacks symptoms, but the symptoms are vague and subtle and easily mistaken for quite a few benign conditions like what you can see in the picture: IBS, IBD, GERD, chronic liver disease, abdominal tuberculosis, just chronic pelvic pain, which has no etiology, PID, endometriosis, peritonitis, and the most dreadful of all, malignancy. So there are various histologies, most common among them in ovarian cancer being a high-grade serous carcinoma. So 80% of these high-grade serous carcinomas present at an advanced stage, making early detection of this silent killer a crucial element in the investigations. So earlier investigations and diagnosis is mainly dependent on understanding the red flag symptoms, and these symptoms being new, persistent, and frequent. These are this phrase, new, persistent, and frequent, is what I'm going to keep repeating throughout this presentation, because that clinches the diagnosis in most. So how would this session proceed here onwards? We will be discussing the key symptomatic warning signs, evidence-based symptom patterns, and how guidelines, that is the major guidelines, that is NCCN, ACOG, RCOG, NICE, and ESGO, approach the symptom-based detection, and when to initiate diagnostic evaluation. So starting off with the key symptomatic warnings, the first and the most important being persistent abdominopelvic symptoms. High-risk symptom cluster, which has been described in the Goff symptom index, which I will be discussing in detail as the slides progress. There are 3 symptoms which have the strongest association with ovarian cancer, that is bloating, pain, and satiety. If we can remember as B, P, and S. So abdominal bloating and increased abdominal size, pelvic or abdominal pain, and early satiety or difficulty in eating. What does the evidence say? It says that women who have had who have ovarian cancer are 6 to 12 times more likely to report the persistence of these symptoms versus controls. Now, other than these, what are the other symptoms? Unexplained gastrointestinal or unexplained genitourinary symptoms. As you can see, unexplained gastrointestinal symptoms are present to the tune of 70% in patients with ovarian cancer. And these are especially more significant if they are being reported by women above 40 years of age, such as indigestion, nausea, changes in bowel habits, either new constipation or new diarrhea, unexplained dyspepsia, and not responding to routine therapy. Often these are misattributed to irritable bowel syndrome or gastritis, but when they are new and persistent, you have to take them seriously. The genitourinary symptoms such as increased urinary frequency, urgency, nocturia, pelvic pressure, these are also present to a tune of 35% in ovarian cancer patients. And especially when they are not explained by other benign conditions like UTI or prolapse, and when persistent, these are also important. The other important cluster being constitutional symptoms such as unintentional weight loss. This is also present to a tune of 50% in women with ovarian cancer. Unintentional loss of appetite, unexplained fatigue, especially in advanced cases who have ascites or abdominal distension. This should raise our flags. The other one being menstrual or hormonal abnormalities. These are slightly rarer, present in about just 10% of the women, because most of the ovarian cancer cases are seen in postmenopausal women and most are non-hormonal in nature. However, new onset irregularity or postmenopausal bleeding should raise our horns. And especially if present with hyperandrogenic features, they're also common in certain tumors, and in certain hormone secreting tumors like granulosa cell tumors, sex cord stromal tumors, and these are more prevalent in premenopausal women. So what are the physical findings that are concerning? I think this, all of us would, take it further if we see any of these findings, such as palpable mass or ascites, which is solid, fixed, or nodular, anything which has ascites associated or pleural effusion associated, which might point towards a Meek syndrome or a metastatic disease. Other red flags in imaging are if an adnexal mass is already seen and they have these following high-risk features such as solid components, papillary projections, which are more common in borderline and low-grade type of tumors, thick septations, high vascularity, if they are bilateral or present with metastatic features such as omental caking, peritoneal masses, ascites, etc. And other thing that we have to keep in mind is the patient profile. A high-risk patient profile, we have to keep our threshold very low for further investigations and even for symptom evaluation. So even mild symptoms warrant evaluation in such high-risk women, that is ones with family history or genetic risk, with, as we all are familiar with hereditary breast ovarian cancer syndrome with BRCA1 and 2 mutation carriers, to the tune of 10 to 15% of ovarian cancers have BRCA1 and 2 mutations. Lynch syndrome is another syndrome. Again, 1 to 3% of ovarian cancers are associated with Lynch syndrome. And first or second degree relatives with breast or ovarian cancers also, we have to keep our threshold low for investigating. Other factors such as reproductive and hormonal factors where nulliparity, infertility, endometriosis, which increases the risk of clear cell and endometrioid subtypes of ovarian cancer, and also obesity. So just summarizing these few slides, high yield clinical triggers are suspect ovarian cancer when a woman, especially above 40 years of age, has new onset bloating, abdominal pain, or early satiety. Symptoms occurring more than 12 times per month, symptoms persisting for more than 3 weeks, and symptoms being new in the sense that their onset is less than in the past 1 year. They also give importance to unexplained GI symptoms, urinary symptoms, ascites, pelvic mass, pleural effusion. Family history plays a very important role, and presence of symptoms, persistence of symptoms despite unusual treatment, despite usual treatment. So let's move on to the evidence-based symptom patterns. I know this is a very busy slide, so I will stay on this slide and explain the points a little more in detail. First, we already spoke about the Goff symptom index. This is the original one, which had its origins from 2004 onwards and got refined by around 2007. This is the bloating, pain, and satiety which I've been talking about. Even if one symptom or more than one symptom is present, which is new, occurring within the past 1 year, frequent more than 12 times per month, or persistent more than for more than 3 weeks, is quite suggestive of an underlying sinister event that is going on. The sensitivity of this index is in early stages of ovarian cancer, it is 56%, in late stages, close to 80%. So it's good sensitivity for late detection. Good specificity of around 90% for women with more than or equal to 50 years of age. So it's the most validated with high specificity and best used as a trigger for imaging in CA125. There is a modified symptom index of the same Goff symptoms, same features, plus urinary symptoms and bowel symptoms and fatigue included. Here, again, the persistent, frequent, and new criteria remain the same. Here, however, the specificity drops a little bit. So, it's more of a research-oriented index. There are various other indexes such as M index, which has similar symptoms included. However, here we note that the specificity increases a little more because more than or equal to 2 symptoms are included in this and not just with 1 symptom. So performance is moderate again. However, the sensitivity drops a little bit. And there are other indices such as this SAOC index, where it's a weighted score, it's a nomogram-based score, and it's more useful in research setting with patient-reported outcomes, where patient-reported outcomes are being measured. And there is an alarm symptom score in which weight loss has been added. However, this again drops down the specificity. And we have symptom index plus CA125 and symptom index plus IOTA ultrasound score. However, these are not purely symptom-based scores, but they do increase the sensitivity and specificity to a considerable extent. So now I saw that various symptom indices exist. However, they have a reasonable sensitivity, but however, they have low positive predictive value to the tune of just 0.6 to 1.1%. So question is, are they endorsed and should we follow them in clinical practice? How do guidelines approach this? We see that NCCN acknowledges the symptom index, that is bloating, pain, and satiety, doesn't name it, doesn't quote it. And it is used to further escalate pelvic examination, CA125, and ultrasound. However, it's not included in any of the algorithms. As ACOG and SGO position, they discuss Goff index, mention its specificity, sensitivity. However, they also note the low positive predictive value, and they recommend clinical suspicion followed by CA125 and ultrasound. Do not endorse any of these symptom scores. How about RCOG, NICE, and BGCS? They use symptom cluster with the frequency to trigger CA125. Followed by this, RMI is calculated and IOTA simple rules have been endorsed in these guidelines. This will be spoken in detail by my next speaker, Dr. Jagannath, who's a close friend of mine as well. However, no formal symptom scores are endorsed. What about European Society position on this? They focus on imaging and biomarkers, and they promote these symptom indices only in quality of life or patient-reported outcome reporting context, and do not endorse it for diagnostic or screening purposes. This is just again a busy slide of all the tools which have been proposed by the guidelines. Again, Dr. Jagannath will be talking about it in detail, but I would just like to highlight the first two where if any of these symptom indices are present, then a CA-125 followed by ultrasound is what has been endorsed by the NICE and BGCS guidelines, and followed by urgent cancer care pathway. RMI is a score which is quite useful, where it is ultrasound is used, menopausal status is used, and CA-125 is used, which has been again endorsed by RCOG, NICE, and BGCS. If it is more than or equal to 200, referral to a gynec-oncologist is prudent. So concluding, when to initiate diagnostic evaluation? Symptoms must be new, frequent, persistent, represent a change from the baseline. Guideline endorsed tools are if there is a high suspicion of cancer, CA-125 with ultrasound, RMI, IOTA, and ADNEX scores have been endorsed. No guideline endorses symptom scores for diagnosis or screening. Thank you all for your patient hearing.
Thank you, Rohini.
Thank you, sir.
Yeah, as always, you speak very well, and elaborate presentation is there. And also, I learned a lot from you. One thing, it is already said that ovarian cancer or adnexal cell mass, all adnexal cell mass should be treated as malignancy unless otherwise proved. So on any age, any age of menopause, any status, if person comes with adnexal cell mass, think we are dealing with malignant cases, and accordingly we should investigate and we should exclude that she is not suffering from malignancy. And there is always a say that it whispers, or adnexal mass, the whispers. You have to put a very sympathetic ear to it, and you will find anything, because the bloatings, all these things what Rohini told, perhaps they are all warning signs. So usually we do not give much of importance to them. That's why we delay the diagnosis. And one point is, when we are doing sending patients for ultrasound, ask for IOTA, and you think of RMA also. There still it holds good to exclude whether it is a malignant or non-malignant cases, and who is going to treat them. So Rohini, it's really great talk, and I enjoyed the talk. Thank you so much, Rohini, for your nice delivery.
Thanks a lot, sir. It's all your teachings and blessings.
Nice talk, Rohini.
Thank you, ma'am.
Usha, please go ahead. Usha, please go ahead.
Yes, ma'am. So our next speaker is Dr. Jagannath. He will speak on tumor markers and risk algorithm for adnexal mass. He is the consultant gynec-oncologist in Tata Medical Setup, Kolkata. Dr. Jagannath.
Thank you.
Dr. Jagannath.
I think he is sharing his screen. Yeah, please.
Right. Is it okay? The screen is visible?
Yes, sir.
Yes.
Yeah, thank you. So good afternoon, everyone. My sincere thanks to Bhagya ma'am, Sheila ma'am, Dr. Ushasri, the Foxy and ICOG team for the opportunity to be a part of this ICOG certification course. So today we'll be discussing about tumor markers and risk algorithms for adnexal mass. After a fantastic talk from Dr. Rohini, and then another fantastic speaker and my friend, Dr. Neetu, next to me, I'm a little bit anxious. So before I begin, here are my disclaimers. So what is a tumor marker? A tumor marker is any substance that is produced by a tumor or by the host cell in response to a cancer cell. These are generally found in cells, tissues, or body fluids, like it could be in ascites, could be urine, could be saliva, in blood, and these are measurable, be it qualitatively or quantitatively. What is the ideal condition for tumor marker? Tumor marker has to be specific. For example, generally we use CA125 for ovarian cancer. It has to be specific for ovarian cancer. It should not be seen any other condition. It should be sensitive. It should be sensitive enough to detect a very low volume of disease. That means it can be used as a diagnosing the early disease or as a screening. And it should be clinically validated. But to find the ideal tumor marker is beyond our science. So what are the types of tumor markers? It could be antigens, it could be cytoplasmic proteins, hormones, receptors, enzymes, oncogenes, and their derivatives. Now, the question comes to mind, why at all we need a tumor marker? Particularly with respect to evaluating the adnexal masses, because we need to differentiate whether we are dealing with a benign disease or a malignant one. So there are symptoms, like Dr. Rohini said, and there are some signs. We as a clinician need to evaluate what are the things we are dealing with. Now, if at all, if it is a malignant one, whether it is a surface epithelial tumor, is a sex stromal tumor, it's a germ cell tumor, because the treatment, the management, the prognosis, everything changes. Now, the commonly used tumor markers in adnexal masses are like CA125, CA19-9, CEA, HE4, alpha-fetoprotein, beta-HCG, lactate dehydrogenase, LDH, inhibin A and B. These are used generally in epithelial ovarian cancer, germ cell ovarian tumor, and sex ovarian tumor. Now, before proceeding to further,
can we do something about the audio? I think people are, there are some remarks that the audio is not clear. Can you go near to your device or something?
Hello? Yes, ma'am. Now is it better?
Yes, Jagannath. Audio is, yeah. I think
is it better,
you can
now?
come closer to the device. Yeah, I think this is better. Yeah.
Okay. So CA125, which is generally commonly used for evaluation of adnexal mass, is a glycoprotein. OC125 monoclonal antibodies are used to identify this, and a general upper limit is 35 for both premenopausal and postmenopausal women. Generally, it is seen in serous variety of epithelial ovarian cancer, particularly the high-grade one. Could be found in low-grade, could be found in endometrioid, clear cell, other varieties of epithelial ovarian cancer as well. Generally, again, it's not that sensitive, but the higher values are generally correlates with the stage. However, it is more valuable as a tool or a marker of treatment response and during the follow-up of the patient after treatment. However, it has many limitations, like it has a poor sensitivity, particularly in early stage of disease. Nearly 50% cases of early stage, we will find the CA125 value is normal. And the specificity, we all know it is much lower because in many benign conditions, it is also seen high. The endometriosis, PID, fibroids, pregnancy, even during menstrual cycle, it varies. So it is not that specific. Another more specific marker of interest is human epididymal protein 4. It has sensitivity almost as CA125. Other epithelial markers that are used particularly for the mucinous or the seromucinous variety, even certain serous varieties as well, CA19-9 and CEA, but these are generally GI, HPV, pancreatic or colorectal markers. However, one ratio, that is CA125 to CEA, if it is more than 25, generally indicates a primary ovarian cancer. These are germ cell and sex stromal tumor markers, which we all know. I'm not going into detail. This is just a summary of tumor markers used in a variety of ovarian cancer patients. Now coming to different algorithms for adnexal mass. As Dr. Rohini said, we have RMI, which is risk of malignancy index, risk of ovarian malignancy algorithm, that is the ROMA. Few other things like OVA1, OVERA, which are generally not used, IOTA simple rules, and IOTA different adnex model. Now, a little bit of history about RMI. RMI generally, it was originally developed by Jacobs et al. In 1990. That is known as RMI-1. And later, Tinglester et al., he wanted to modify this due to some certain limitations. And RMI-2 and RMI-3 both were developed by Tinglester et al. Next, Yamamoto et al. Developed RMI-4. Basically, the RMI uses ultrasound score, then menopausal status score, and CA125 value. If RMI-1 particularly, if the level is more than 200, then it indicates a high risk of malignancy. This is RMI-1 and RMI-2, 3, 4. 4 generally uses, other than ultrasound, menopausal status, and CA125 a size criteria. But RMI-1 is the validated one, is generally used in clinical conditions. ROMA in 2009, Moore proposed ROMA. It uses the CA125 and HE4 levels along with menopausal status because HE4 is thought to be more specific than CA125. Basically, using ROMA, it gives us a predicted probability and expressed by a percentage rate, which classifies the adnexal mass into a high risk or low risk variety of malignancy. Other algorithms used, generally not used, but was evaluated in different patient populations. One is Copenhagen index, another is ROMA-P. These are generally mathematical models using CA125, HE4, and age of the patient. Here, menopausal status was not taken into consideration. However, these algorithms failed to show any improved sensitivity or specificity as compared to RMI-1. Then certain biomarkers use best algorithms like OVA1 and OVERA. OVERA is just a second generation version of OVA1, which uses 5 biomarkers like CA125, prealbumin, apolipoprotein A1, beta-2 microglobulin, and transferrin. It has a good sensitivity but high false positivity rate. Which the OVERA1 tries to overcome the OVA1, which replaces the prealbumin and beta-2 microglobulin with HE4 and SSH to improve the specificity rate, but it has its own limitations because these are generally not validated in different clinical conditions. Now coming to IOTA, perhaps my next speaker will speak in detail about the IOTA because he has talked on ultrasound. So IOTA was generally was first published by Timmerman et al. In 2000. They first provided certain terms and definitions: what is unilocular, what is a solid, how the cyst contains, what is anechoic, what is low level, how solid material is measured, what is a papillary structure, what do you mean by wall irregularity, how to differentiate between wall irregularity, how to measure the vascularity, what do you mean by shadows, and how to define ascites. Everything was defined by the IOTA group. Then after that, they came with some simple descriptors, easy to find pattern recognition: endometrioma, dermoid, simple cyst, hemorrhagic cyst, ascites. These are easily identifiable patterns. That means this is the second step. If simple descriptors do not apply, then apply the simple rules. They came in 2008 with certain simple rules, M rules and B rules, 5 rules in each component. The rule 1 is the mass will be classified as benign if at least one B feature is present, but no M feature. Same thing goes for the rule 2, malignant if at least one M feature is present but no B features. Rule 3 is if both features are present, then the result is inconclusive and we have to perform the second stage investigation. Now, to overcome this, I would again propose a ADNEX model. ADNEX model is assessment of different neoplasias in adnexa, which is the most validated model internationally. It has a good sensitivity and specificity as well. Here we use 3 clinical predictors and 6 ultrasound predictors. Clinical predictors are age, serum CA125, and type of center. Type of center means whether it is a community level center or a tertiary cancer center, and certain ultrasound parameters. After using this, they will provide you a relative risk of having a benign disease, a borderline disease, or it is an early stage-wise division, or it is a secondary metastatic cancer to the ovary. But at present, this model is not available for use. Generally, you will find a web page or app-based model from the IOTA, but due to certain regulations from the European Medical Agency EMA, they are undergoing some scrutiny. After that, they will come with after proper approval. But generally, it will look like this. It will give us relative risk best score. What is the chance of? What is the risk of a malignancy? What is the risk of benign? What is the risk of being a metastatic cancer? Now, which algorithm to use in clinical practice? Preferred is the IOTA. If expertise is limited, RMI1 is alternative. For a biochemical marker-based risk, ROMA, IOTA simple rules can be used for rapid trials. My now take-home message is tumor markers support, but they do not replace clinical and radiological evaluation. CA125 and HE4 are most important for the epithelial cancer. Germ cell markers are generally used for young patients less than 40 years. IOTA ADNEX is most accurate and comprehensive risk model. Always combine clinical, biochemical, and imaging for evaluating adnexal markers. Thank you.
Thank you. Thank you so much, Jagannath, for a very nice and elaborate talk. So I think according to your talk, it's not only tumor markers, it has to be combined with all these, it has to be together with all this even simple rules, RMI, tumor markers, all together, we can reach on a proper diagnosis. Okay.
Yes, ma'am. Yes, ma'am.
Okay, thank you. Thank you. It's very nice.
Thank you. Yeah.
Jagannath, people wanted to see you, but then I don't know what really happened with your video. And
no, I think you have his talk was also breaking like.
Yeah, I think the network is not very good. But I think you have to stay back in the question answer session and explain about RMI.
Yeah, I'm here only. Yeah, ma'am.
Yes. Usha, please go ahead.
Our next speaker is Dr. Neetu PK. She will speak on imaging for adnexal mass. Madam, Dr. Neetu.
Yeah.
She is a gynec cancer surgeon from Amrita Institute of Medical Sciences, Kochi.
Is it visible?
Yes, ma'am.
I'll make it full screen.
Yes, ma'am.
Okay. So a very good afternoon, everyone. Respected chair, my teachers, and thank you for being making me part of this. Bhagya madam, very thank you. So this is about imaging for adnexal mass. My question was ultrasound, MRI, CT, who gets what? I think almost everything has been covered by Jagannath sir, but I'll try to make it a little more interesting, but skip through some without getting it very repetitive for you. So adnexal mass diagnosis. In the early 1970s, the term postmenopausal palpable ovary syndrome was coined to alert gynecologists to the possibility of ovarian cancer in postmenopausal patients with palpable ovaries. In 1970s, ultrasound enabled conservative management of benign lesions and surgical referral for suspicious ones. In 1970s and 80s, CT improved the diagnosis of simple lesions but struggled with complex ones. Late 1980s and 90s, MRI added superior tissue characterization, and 2010 onwards, risk stratification systems like IOTA, ORAD, standardized and improved management with MRI-based scoring systems emerged for complex cases. So most of my talk will be based on this ESGO, IUSOG, IOTA, SG consensus statement about the diagnosis of ovarian tumors. So I'll just start with it. The accurate characterization of a newly diagnosed adnexal lesion is of paramount importance to define appropriate treatment. So the treatment decision-making process should be based on a combination of patient's overall picture, symptoms, preferences, previous medical and surgical history, tumor markers, clinical and radiological findings. A single diagnostic modality cannot determine the patient's journey. So what about the first one, ultrasonography? A transvaginal ultrasound is the first step in clinical practice as a standard imaging investigation for the assessment of adnexal pathology. The diagnostic accuracy of ultrasound in differentiating between benign and malignant has been shown to relate to the expertise of the operator. It depends on the experience of the operator. So how do we level the training and expertise? A level 3 expert can be attributed to a practitioner who is likely to spend the majority of their time undertaking gynecological ultrasound and or teaching, research and development. Level 2 would have at least undertaken 2000 gynecological ultrasound. To maintain competence, he should be doing at least 500 examinations per year. And a level 1 should have performed a minimum of 300 examinations under the supervision of level 2 or a level 1 with at least 2 years regular practice. To maintain level, he should do at least 300 examinations each year. So there has been studies which show that women with a level 3, that is an expert ultrasound examination, undergo significantly fewer unnecessary major procedures and have a shorter inpatient hospital stay compared with those having level 2 examination by a sonographer. Risk of malignancy index, already Dr. Jagannath sir has covered it. I wouldn't repeat it. So what is often used as alongside other models, because it comes with ultrasound, I'll just cover it through. IOTA, adnex and ROMA. It remains a cornerstone in adnexal mass evaluation. Though the cutoff of 200 is commonly used, the accuracy is lower for mucinous tumors because in mucinous tumors, CA125 is not that elevated. There are 3 other variants, but these offer no additional diagnostic advantage. Limitations would be absence of an estimated risk. They don't give a number, and considerable dependency on CA125, resulting in a relatively low sensitivity for early stage invasive and borderline disease, especially in premenopausal. ROMA is already covered. I'll come to IOTA. IOTA already Jagannath sir has given outline. So it is for estimating risk of malignancy. It combines clinical data and ultrasound features. There are a set of standardized ultrasound rules to classify adnexal masses as benign or malignant. 10 sonographic features, simple, reproducible, widely validated. 25% can be inconclusive. Already covered the simple rules, B1, B2, unilocular solid component. I'm sure everybody already heard that. So we have only B features, benign, only M features, malignant, inconclusive, both M and B. What about likelihood ratios? They quantify how much a feature changes the probability of malignancy. LR plus, positive likelihood ratio, how much more likely malignancy is if feature is present. LR negative, negative likelihood ratio, how much less likely malignancy is if a feature is absent. For IOTA rule, studies have shown that the M malignant features M1 to M5 generally have high LR plus values, meaning their presence strongly increases the probability of cancer. And benign features have high LR negative values, meaning their presence strongly decreases the probability of cancer. When both benign and malignant features coexist, that is inconclusive, risk prediction models like ADNEX or expert review are recommended. So ADNEX, already we have seen how it is. So the limitations is that it requires CA125 and is a more complex input. Input variables, 9 predictors are there. Clinical data, age of the patient, serum CA125, type of cancer center, ultrasound features like max diameter of the lesion, max diameter of the largest solid part, number of locules, number of papillary projections, presence of acoustic shadows, and presence of ascites. Output categories, it comes as 5: benign, borderline, stage 1, stage 2 to 4, or secondary metastatic tumors. Adnex, unlike IOTA simple rules, Adnex doesn't just say benign or malignant, it gives specific tumor categories, helps triage patients to appropriate centers, and large multi-center studies show good accuracy. So this is a outline of all the ultrasound-based predictor models. So we can see that the simple descriptors, there is no risk estimates based on clinical ultrasound and CA125 information, and possible to calculate result without computer. That is the thing about simple descriptors. RMI also no risk estimates. Clinical ultrasound CA125 possible to calculate result without computer. Online calculators are also available. Simple rules, no risk estimates. Classification into 3 groups based on dichotomized ultrasound features, easy to use without computer, and available as a smartphone app. Likelihood ratios, there are also risk estimates based on clinical ultrasound, requires computer, available as a smartphone app. There is simple rules risk model, which gives risk estimates based on dichotomized ultrasound features, developed to add risk estimates for simple rules, available as online calculator, ultrasound machines also sometimes. And Adnex, with and without CA125, without CA125, already gives the risk estimates, 4 types of subtypes of malignancy based on clinical ultrasound. Subjective predictors are avoided as a priori, requires computer, available on smartphone and online calculator, sometimes in ultrasound machine. Same with CA125 Adnex model as well. So there are other scores, GIRATS, which is introduced Amor et al. In 2009 and validated prospectively. It gives 1, 2, 3, 4, and 5, 5 being very high probability of malignancy. Studies have demonstrated the value of GIRAT system for the assessment of malignant adnexal masses in women who are candidates for surgical intervention. The addition of GIRATs to CA125 improves identification of adnexal masses at high risk of malignancy compared with using CA125 alone. ORADS, the Ovarian Adnexal Reporting and Data System Lexicon for Ultrasound, was published in 2018, providing a standardized glossary. It's a glossary, it's a lexicon that includes all appropriate descriptors and definitions of characteristic ultrasound appearance of normal ovaries and various adnexal lesions. The ORADS Ultrasound Working Group developed an adnexal mass triage system based on either ORADS descriptors or the risk of malignancy assigned to the mass using the IOTA Adnex model to classify ovarian tumors into different risk categories. It is also developed by the American College of Radiology. It is also has 0 to 5, 0 being incomplete evaluation, normal ovary 1, 2 almost certainly benign, and 3 low risk of malignancy. We are more worried about 4 and 5, where the risk of malignancy is 10 to more than 50 in ORADS 5. Key ultrasound features considered are morphology of the mass, whether it is unilocular, multilocular, solid, papillary projections, size and structure of solid components, presence of ascites, Doppler blood flow, acoustic shadows, strengths, provides clear management recommendations based on risk category, standardized lexicon, improves communication between radiologists, gynecologists, and oncologists, widely adopted and validated in clinical practice. ORADS ultrasound is a structured risk-based system for adnexal mass evaluation. It complements IOTA simple rules and Adnex model. So this is what we have seen. If you can see the last one, we can see that ORADS is a standardized reporting, integrates risk modeling. GIRAT simple grading, easy to apply. IOTA is quick bedside classification and is widely used. So what are the consensus statement for ultrasound? Expert ultrasound examiner is the best. It's still humans are the best. Models useful if expert is unavailable. IOTA symbol rules risk or Adnex is much better than CA125, HE4 or Roma alone. Adnex and symbol rules risk outperform RMI. Adnex differentiates benign, borderline, early, advanced, or metastasis. Threshold for metastasis suspicion in Adnex is almost 10%. For tumor markers, already we have seen CA125 is the best, but not for screening. HE4 Roma, no advantage, no added advantage. CA125 doesn't improve ultrasound models. helps subtype distinction. CA is useful for primary versus secondary tumors. 99 helps identify secondary metastasis. What about MRI? MRI is used as a second line imaging tool when ultrasound is inconclusive. This is the first and foremost. Key features are multi-parametric MRI, T1, T2, diffusion weighted imaging, contrast enhanced sequences are necessary. High specificity in differentiating benign versus malignant, useful for staging. More expensive, less available, requires expertise. The quantitative dynamic contrast enhanced MRI to diffusion weighted imaging and anatomical MRI sequences and the development of a 5-point scoring system, the ORADS MRI, is another modern diagnostic development with promising potential for the differentiation between benign and malignant head neck cell masses. When this technique is enhanced with volume quantification, it can help to discriminate type 1 and type 2. Diffusion weighted imaging is highly sensitive for the depiction of peritoneal metastasis. In combination with gadolinium enhanced imaging, diffusion weighted imaging has been shown to be more sensitive than CT in the depiction of peritoneal metastasis in some studies, but is often limited by diaphragmatic and bowel motion. So there is an ORADS MRI also, which is from ACR. It is standardized MRI-based risk stratification. Uses multi-parametric MRI to classify head neck cell masses. It is a reliable second-line imaging tool when ultrasound is indeterminate. So it also has 1, 2, 3, 4, 5, 5 being high risk of malignancies. What are the features? Morphology, solid versus cystic, papillary septations, T1, T2, signal intensity, fat content, hemorrhage, diffusion restriction, high cellularity, often malignant, contrast enhancement, type and intensity of enhancement patterns, associated findings like ascites, peritoneal implants, lymphadenopathy. So key takeaways are, it's a standardized multi-parametric MRI-based system for neck cell mass evaluation. It complements ORADS ultrasound, IOTA at necks. There are studies like ESCODIA and MROC which are coming up, will say how much useful an ORADS MRI is. About the computer CT, dedicated multi-detected CT protocols with standardized peritoneal carcinomatosis index forms are the most common diagnostic tool used in routine clinical practice to assess the extent of tumor dissemination and the presence of peritoneal carcinomatosis. It should not be used as a sole tool to predict resectability. Rather, it should be used as a first-line diagnostic tool to identify patients who should not be selected for cytoreductive surgery, such as those with large multifocal intraparenchymatous distant mets, acute thromboembolic events, or secondary mets that limit the prognosis. Radiomics may improve CT accuracy in the future, but more validation is needed. PET CT may be useful in differentiating malignant from borderline or benign malignant tumors, but it shows low diagnostic value when it comes to differentiating between borderline and benign tumors, and diagnostic performance can be impacted negatively by certain tumor histologies because lower FDG uptake in clear cell and mucinous. It also plays a role in as an additional technique for lymph node metastasis and key areas like chest lesions. However, PET-CT does not seem to be a relevant additional diagnostic modality for the true extent of peritoneal spread of ovarian cancer, specifically bowel and mesenteric serosa, and therefore fails to predict resectability in those key sites, especially in low volume disease. So what are the statements for imaging? MRI, DCE, diffusion weighted imaging is second line after ultrasound. PET-CT, diffusion weighted imaging MRI detect non-ovarian metastasis. PET-CT cannot separate borderline versus benign. Imaging alone is insufficient for peritoneal or mesenteric spread. Imaging alone should not guide surgical resectability. So what is the final workflow looks like when the patient comes with symptoms? First is an ultrasound suggestive of a normal ovary or a physiological finding, that's an ORAS1. You go for conservative management, discharge or repeat after 6 weeks. It is non-physiological expert ultrasound assessment, that is first, or IOTA adnex. And then you have a risk less than 1% if it's ORADS2. If asymptomatic, you do a conservative management, follow up 3 to 6 to 12 months. Low risk of malignancy, ORADS3, surgical management in the general gynecology unit. But if it's an ORADS4 with an intermediate risk of malignancy or a high risk of malignancy, ORADS5, you refer to a specialist gynecological center. So what happens in the center? We use we can use diffusion weighted, perfusion weighted MRI, expert subjective assessment, aorta adnex with CA125, CA125 CEA, and other tumor markers in specific cases. Finally, there will be a specialist in charge and a MDT meeting, and the staging procedures, everything is discussed, and we have decision on borderline, early stage, advanced stage, or a secondary metastasis, and accordingly managed. So this is about a comparative study, comparative review of 5 national guidelines from US, UK, Canada, France, and Australia. And the conclusion is, broad consensus, ultrasound is definitely first line, MRI for indeterminate lesion, and you should avoid aspiration. And variations are, so they don't decide, they don't agree on Doppler use, biomarker thresholds, and surveillance intervals. Clinical implications are, guidelines provide spectrum. The clinician should tailor management. So what is the role of AI and radiomics? Further, radiomics helps extract numerous quantitative features from medical images, revealing hidden patterns undetectable by humans. The AI can enhance radiomics, and deep learning models can augment the data sets. Precision oncology impact. AI and radiomics enable objective assessment, identifying subtle biomarkers linked to treatment and survival. That's it. Thank you. I hope I didn't bore you.
Please unmute Dr. Sujata Mishra.
Sujata is not there.
Yes, she's there, but she's
Everybody
muted, I
to
think.
sleep, I think.
Yeah.
She slept off.
Shreya?
I think I put everybody to sleep.
No.
Shreya, Shreya.
Yes, ma'am, Kia.
You've
Please
covered everything.
unmute Madam Sujata Mishra, Madam.
Now, is it okay? Can you hear me?
Yes.
Yes, ma'am.
Yes.
Okay. So thank you, Dr. Neetu. That was a very, very, very exhaustive covering of imaging as a diagnostic tool for adnexal masses. While you still said that ultrasound is one of the best, you also went on to talk about USG, MRI, CT, AI, and all those models, IOTA, adnex, Roma. But what I think we appreciated, being one of those non-oncology persons maybe out here, is the last few slides where she showed the entire flow, that flow pattern. I think was a very nice thing as to how we can go on.
Yes.
Thank you so much. That was very nice.
Thank you. Thank you.
Nice to see you, Sujata.
Hi, Sheila. Giri
Hi.
sir ko namaskar. Jita is also there.
Yeah.
Yeah, hi.
Namaskar.
I thought Sujata you slept off.
This was really informative and educative.
Yeah,
and I've
yeah. She
copied a
covered.
couple of slides to show it in the department here also.
She has
You
showed almost everything.
you will get the recording on website. I mean, the
that's
PGs.
excellent.
Yeah.
Okay.
Thank you.
Okay. That's very
PGs
nice.
can access that from
Yes.
ICOG website.
It's really very helpful. Thank you.
Yeah.
Thank you
I
so
think,
much.
Shreya, we have 5 minutes for question answer session. We have Dr. Soni on to take the questions. Soni, please start.
So there's a question.
Yeah, please start.
Question in the chat box for Dr. Jagannath Mishra, sir. So please explain regarding RMI1 and Roma. Jagannath, sir, are you there?
Yeah.
I think please, Jagannath, please explain briefly about RMA again, because there's a lot of requests from the participants.
And he should be on the video too, not
Sir, are
only
you there? Okay. Yes, sir.
Yeah.
Yes.
So RMI
Not audible.
RMI is risk of malignancy index. It uses ultrasound-based score and menopausal status and CA125 value. CA1, for example, I will give you an example. So, for example, there is a solid cystic mass, but there is no ascites. There is no, or you can say, moderate color flow. And she is 56 years old, postmenopausal lady, with a CA125 value of 76. Now, how to calculate RMI1? RMI1 says if ultrasound, there are different scores assigned to different features. Like, for example, if it is a unilocular cyst, the score is 0. If it is multilocular, again, multilocular size, solid presence of solid components, papillary features, those things. So ultrasound score is 0 if there are none of the features, none of the malignant features are present. If score is 1 if it is only one feature is present, and it is 3 if more than 2 features are present. So, for example, if none of the features are, for example, in my case, particularly solid with color score of 2, so more than 2 equal to 2 is score is 3. Age is 56 and postmenopausal, score is again 3. 76 was the CA125 value. So you multiplied 3 into 3 into 76. So that becomes more than 200. So that lady carries a higher risk of malignancy. So similarly, Roma is a mathematical model actually, which uses CA125, HE4, and menopausal status. So you put that the values into a model. It's a different model. Again, the value cutoff value varies from lab to lab. For example, if you use the lab Rose, the cutoff value for premenopausal, I think it was around 13. If you use Abbott, it varies. The laboratory gives you the score and it gives you the report of whether that lady carries a higher risk of malignancy or a lower risk of malignancy. So again, these models are used for prediction whether the adnexal mass we are dealing with is a malignant one or a benign one. Accordingly, whether it will be treated by a general gynecologist or by a gynecologist in oncology setup.
So I think we can take one more question only. Yes. The rest will request all the speakers to take it on the answer them on the chat box. I think one more question only we can.
There's another question. What is ORADs?
So Nitu, could you briefly tell about ORADs? I think Nitu is away from her device.
No, madam, I was just not loud enough. Can you hear me now, ma'am?
Yeah, ma'am, it's audible. Yes.
Yeah. So ORADS is basically, if the full form, it is Ovarian Adnexal Reporting and Data System. It's a lexicon. It's just a standardized glossary where they describe all the findings so that everybody says the same language. So they use all appropriate descriptors and definitions of the characteristic ultrasound appearance of normal ovaries and various adnexal lesions. And then they have made a adnexal mass triage system based on this glossary. So that is what is the ORADS descriptors. So they have risk categories. So depending on these ultrasound descriptors, they have assigned a risk. This is all computerized, this thing. And then finally we have risk. And according to the ORADS, 4 and 5 have high risk of malignancy. And whenever you see 4 and 5, you have to be very you have to refer to a gynae oncologist. So the key ultrasound features are morphology of the mass, if it's unilocular, multilocular, solid, papillary, size and structure of the solid components, presence of ascites, Doppler blood flow, and acoustic shadows. So it is a clear management recommendation based on risk category. That is why it's basically a standardized lexicon, that is a language for the radiologists and gynecologists and oncologists to understand. That's all. Am I clear?
Yes, ma'am.
Should I?
No. Yes, ma'am.
I think Mushka, please go ahead with the second session. So request all the speakers to please answer the questions on the chat box. Thank you, Soni.
So our next session is on surgical principles of ovarian cancer. The chairperson is for the same hour, Dr. Jyoti Meena. I think Jyoti Meena ma'am will be late. She has some emergency. And second chairperson is Dr. Anupama Bahadur. She is professor, unit head OBGY in AIMS Rishikesh. And the third chairperson is Dr. Lata Chaturvedula. She is professor OBGY in JIPMER. Our first speaker for the session is fertility sparing options. Next, Dr. Anjana. Next speaker is Dr. Anjana JS.
She has some problem, so we go ahead with Anjana.
Yeah. Dr. Anjana J. She is consultant gynec oncology in Cosmopolitan Hospital, Trivandrum. She'll speak on fertility sparing options in ovarian cancer.
Did we say something?
Can you hear the? Can you see the slides?
Yeah.
Yes.
Okay, thank you.
Yes.
Good evening, all. Thank you, organizers, for giving me this opportunity. I'll be presenting on fertility sparing options in patients with carcinoma ovary. By 2030, WHO estimates that around 4 lakh new cases of carcinoma ovary will be reported and around 2 lakh 74 deaths will be reported globally. But we all know there is a rising trend in delaying childbearing. Higher number of patients who have not completed their family are getting diagnosed with carcinoma ovary, and many young patients are also getting diagnosed with carcinoma ovary. But in these young patients, they might get like easily curable diseases, and as there is better cure rates, there mandates reason for fertility preserving options in these patients. So when we hear carcinoma ovary, we get so much doubts. Many of us consider it as an aggressive disease. So the question arises, are all ovarian cancers suitable for fertility preservation? What all should we consider before fertility preservation? How to do the fertility sparing surgery? How to manage the patient after that? And what are the evidences on oncological and reproductive outcome? So let us see what are the ovarian cancers which are suitable for fertility preservation. As we all know, there are 3 kinds of ovarian cancers. The surface epithelial ones like the serous, mucinous, endometrioid. The sex-cord stromal tumors like the granulosa, thecoma, Sertoli, Leydig. The germ cell tumors like dysgerminoma, yolk sac tumor, mixed germ cell tumor, etc. So let us first see the germ cell tumors which are more common in young women. Even though germ cell tumors constitute only around 2 to 3% of all cases of ovarian malignancies, they constitute 70% of all ovarian neoplasm, which are seen among adolescents and young women. But the good thing here is that they are highly chemosensitive, so we can cure majority of these patients. And germ cell tumors usually arise, they are usually unilateral, but bilateral involvement might be present in around 10 to 15% patients of dysgerminomas, 5 to 10% patients with mixed malignant germ cell tumors. So if the patient is having a unilateral early stage tumor, the surgery preferred is unilateral salpingo-oophorectomy along with staging. What we should remember here is biopsy of the contralateral ovary is not recommended if it appears normal, as it might lead to premature ovarian failure or other complications. But unfortunately, if the patient is having a bilateral disease, what is generally recommended and what we should try to do is salpingo-oophorectomy on the side of larger tumor and a cystectomy in the smaller one. This should be considered as the patient is like the disease is chemosensitive. But if the patient is having an advanced stage disease, still then we should attempt for a conservative management. That is, we should try to preserve the uterus and at least part of the ovary. Being highly chemosensitive, these patients are curable, mostly curable with the post-adjuvant chemotherapy. Another option for this advanced stage disease is neoadjuvant chemotherapy followed by fertility sparing surgery. We had published our own data from Regional Cancer Center, around 25 patients. We had a very good survival, and majority of the patients we could do fertility sparing surgery. And so in germ cell tumors, the majority of patients have normal menstrual and reproductive function after fertility sparing surgery and chemotherapy. Routine completion surgery is not routinely indicated after childbearing, but if the patient is diagnosed with gonadal dysgenesis, then we should go for bilateral salpingo-oophorectomy. So coming to borderline ovarian tumors, which is very common in this age group, we know that here there is uncontrolled epithelial proliferation and ectypia, but there is no stromal invasion. And majority of the borderline tumors are seen in younger women, so they're usually present in reproductive age group. But the good news here is majority are stage 1 and is associated with a good prognosis. As we all know, there are many varieties of borderline tumors like serous, mucinous, endometrioid. Serous borderline tumors, if it is coming as an unilateral tumor, it is preferred to do a unilateral salpingo-oophorectomy along with staging. But in 1/3 patients, there can be bilateral disease. In such patients, we should go for a salpingo-oophorectomy on the site for the larger tumor and attempt for a cystectomy in the site with the smaller tumor. Even bilateral cystectomies can be considered, as a rate of spontaneous pregnancy ranged between 30 to 80%. But in stage 2 or stage 3 serous borderline, if there are implants, then we should extensively counsel the patient for fertility sparing treatment, as there is high chance of recurrence, and only in selected patients we should go for fertility sparing. Coming to mucinous borderline, the news about mucinous borderline is it usually presents as a unilateral disease, but they are huge tumors. But so we should generally not attempt cystectomy. As it is a unilateral disease, we should try for unilateral salpingo-oophorectomy in order to decrease the risk of recurrence, and there might be foci of malignancy in this borderline tumor also. So there are data which suggests that after conservative surgery, there is increased chance of recurrence as compared to radical surgery. But the good news here is that most of the recurrences are surgically salvageable. So coming to sex cord tumors, few sex cord tumors like granulosa cell tumor can also come in young patient, but most of them are stage 1. And these patients, especially stage 1A, can be managed by fertility sparing treatment. Prognosis is usually very excellent, but we should keep the patient under prolonged surveillance, as late recurrences are also very common among these patients. Coming to the epithelial ovarian cancer, this is one cancer which we are all worried. Seeing epithelial ovarian cancer, we might all consider for a total surgery, as we might think all the epithelial tumors are aggressive. But around 15% patients, epithelial ovarian cancer can occur in women who are 40 years. And in these patients, they have more chance of getting localized disease, and the 5-year survival might be around 90%. Another thing is, when we say epithelial ovarian cancer, it is not a single disease. There are multiple pathologies which come under epithelial ovarian cancer, many of which are treatable by fertility sparing treatment. So we should think about the histopathology, the grade, the stage, and then when we deal with this patient, we should consider about the chance of recurrence in opposite ovary, how we should proceed, whether we can do laparoscopy, whether we should do laparotomy. There are other oncological outcomes which we should consider when we deal with an epithelial ovarian cancer. Definitely, fertility sparing treatment is feasible in few types of epithelial ovarian cancer, and pregnancy is possible after treatment too. According to guidelines, fertility sparing treatment can be offered to all stage 1 and stage 1C1 low-grade ovarian epithelial ovarian cancer like serous, mucinous, endometrioid. What we should be not here specifically is it is low-grade. If it is either should be low-grade serous or mucinous or endometrioid grade 1 or 2, and the stage should not be more than stage 1. The mucinous tumors like borderline presents usually in stage 1, and they have a very good prognosis. But we know mucinous tumors are not a single thing. Both expansile and infiltrative kinds are there, and various retrospective data has shown both for expansile as well as infiltrative, we can try for fertility sparing treatment, as there is no difference in survival by the type of mucinous tumor. Clear cell carcinomas are usually very aggressive. There is no much data which which definitely say fertility sparing treatment is safe in patients with clear cell carcinoma. When we deal with a patient with clear cell carcinoma, we should be especially careful, as the rate of recurrence is much more. Coming to grade 3, there are data which shows even in stage 1A, if the patient is having a grade 3, that is high-grade serous or grade 3 endometrioid, the recurrence risk is very high. So fertility sparing treatment is contraindicated in patients with grade 3 disease. So as summarizing, come to the pathology, it is very safe to offer fertility sparing surgery in patients with low-grade serous carcinoma 1A and 1C1, all mucinous carcinoma 1A and 1C1, germ cell tumors, granulosa cell tumor 1A, and Sertoli Leydig cell tumor 1A. The safety is undetermined in low-grade serous carcinoma C2, clear cell carcinoma even in 1A, mucinous carcinoma 1C3, expansile type. and in adult granulosa cell tumor 1C1 also. It is unsafe in low-grade serous carcinoma 1C and more than stage 1, mucinous carcinoma 1C3 infiltrative, clear cell carcinoma from 1C2, and juvenile granulosa cell tumor more than stage 1A. So here we have seen about the pathology. What other things we should consider prior to offering fertility sparing treatment for a patient? We should all keep in mind that there are no randomized trials dealing with this subject. So when we offer the patient fertility sparing treatment, we should properly counsel. We should select the patient appropriately. The patient should be of the reproductive age group. She should have a strong desire for pregnancy. Then she should be counseled about the standard treatment, the deviation from the standard treatment, and the outcome of oncological outcome as well as the fertility outcome after treatment. And she should have a realistic expectation even with ART. The patient should be treated in a center with most experience and expertise. The treatment should be multidisciplinary. And what we should all keep in mind is optimal cancer therapy should always supersede fertility preservation as the primary objective. And we all know pathology of many of these tumors might be unknown preoperatively, and this has to be discussed with the patient. The outcome can be either benign, borderline, or malignant, and many of the time we have to make a decision intraoperatively as well as with the frozen section. The frozen is not totally safe is what we should counsel the patient. There might be many false positive or false negative. The sensitivity and of frozen is much better in a benign tumor, but it is not so reliable in a malignant or border, especially in borderline cases. So more false negative might be there in a borderline tumor followed by malignant, and it's best for the benign disease. Always the fertility sparing treatment should include surgical staging, as around 30% patients there might be upstaging due to occult metastatic disease, and there are various data which suggest that the recurrence is quite less in patients who did not have adequate staging as compared to patients who had a proper staging. We should do a thorough staging, peritoneal cytology. Then we have to remember in the contralateral ovary is normal in a unilateral disease. We need not go and biopsy that ovary. We should take a multiple peritoneal biopsy, nomentectomy, and enlarged nodes also should be removed. Another question which comes to us is whether we should go for a laparotomy or laparoscopy. As I said, many of these patients are very young patients who might present with a complex mass of around 15 or 20 centimeter. And then the question might arise, why should we give a very big scar for this patient? Why can't we do a laparoscopy? But what we all should remember is we are dealing with ovarian cancer, and we should first do no harm to the patient. There are many problems. If you are doing laparoscopy in a large malignant ovarian mass, there is risk of tumor spillage, as ovarian cancer is a peritoneal disease. The disease might spread throughout the peritoneum. There is risk of port-side metastasis, scar recurrences, which might accelerate the malignant spread. And there is a risk that the carbon dioxide also might contribute to cancer spread, as the acidic milieu might favor tumor implantation. So even if a small mass we are trying to take it out by laparoscopy, what we should be very careful is there should not be any spillage. So does the spill matter? Even though RCTs are not there, there are large retrospective data which suggests that intra-op rupture was an independent risk factor for poor survival. Coming to oncological outcome, when we follow up the patient, one thing we are always worried is whether there will be recurrence in the outside the ovary which we have kept. Even though rare, they can be recurrences which can be salvaged by surgery. But prognosis is affected mainly by the extra-ovarian recurrences, which are same as radical and fertility-sparing surgery. And data suggests good outcome in patients after fertility-sparing surgery, including obstetric outcome. So, fertility-preserving treatment in malignancies is a need of the hour, but we should always keep in mind we should not compromise the oncological outcome. Patients should be properly counseled. The management should be in a specialized center, ensuring that patient gets a very good outcome. Thank you.
Good evening. That was a very good presentation, Anjana. I think there are some questions, and I could have some things to ask maybe at the end of the session, Dr. Bhatia. Hello?
Ma'am?
Should we ask the questions at the end of the session?
Yes, ma'am. We'll take the question at the end of the session, but if you have any comment regarding the talk, then you can.
Yeah, just one thing, Angela, you have not told about the completion surgery following any of these tumors where we do conservative management, especially after the expressive. You want to say something about that?
But I mean, usually in patients with germ cell tumors, we don't routinely advise a completion surgery. But there is not much data on all other, even other malignancies also. But we suggest the patient to get pregnant soon and then go for a completion surgery in epithelial ovarian cancer soon.
Because we've had a patient that sometimes we do see these patients during the cesarean or something like that. So we have done ovariotomy that has come as mucous sarcoma, stage 1A luckily. And this patient went on to have a second child. And 10 months later, I was in a dilemma, very young. She was only 25. Whether to operate. So a lot of deliberations. Patient wanted to go ahead with the completion surgery. We just did, waiting for the histopathology to see if any. Yeah. These are no data you have to, I think, take with individual patients and see about it. I think with that, I'll stop here. I think the next presentation can go on. Thank you.
Thank you.
Our next speaker is Dr. Vaishali. Dr. Vaishali Paliwal is consultant gynec-oncology at Max Institute of Cancer Care, New Delhi. She will speak on basic principles of surgery in ovarian cancer. Dr. Vaishali.
Vaishali ma'am.
Is my screen visible?
Yes, ma'am.
Yeah.
She has to make it full screen.
Now it's okay? Visible?
No, you make it full screen.
It is full screen on my side. नहीं आ रहा है अभी भी full screen.
Ma'am, you are logged in with the two device, ma'am.
Okay. Just give me 1 minute.
Ma'am, click on the play.
Play. Resume.
ऊपर बार में play है ना? Play on that. हाँ ऊपर.
This one.
तुम ना सेकंड जो डिवाइस है वो क्लोज कर दो और यहाँ पे देखो व्यू जूम एड स्लाइड प्ले है ना, वो प्ले पे क्लिक कर दो. उसके लेफ्ट में शेयर कमेंट मीडिया शेप टेक्स्ट फिर प्ले है.
प्ले तो कहीं आ नहीं रहा है.
नहीं ऊपर
मैम
लिखा हुआ है
ऊपर के साइड में देखो, जहाँ लेफ्ट हैंड साइड में व्यू जूम एड स्लाइड लिखा है वहां पे देखो प्ले है मैम.
Oh, okay.
हाँ.
Okay, sorry. Is it now full screen?
Yes, ma'am.
Okay. Sorry, there was some technical issue. So, good evening, everyone. I'm going to speak on basic principles surgery for ovarian cancer. So, I have kept the presentation very simple because we have limited time. Okay. So, as we all know that ovarian cancer is the most lethal gynecological cancer. It is the third most common cancer in women in India. The incidence is increasing rapidly. It is the highest disease-related mortality among gynecological malignancies because of its aggressive biological behavior, and 70% of the cases are diagnosed in advanced stages. Cure rates are good for early stage disease, but they are poor for advanced stage. And over 15-20 years, the survival has not improved drastically. So it needs an aggressive therapeutic approach for optimal results. Now, as we all know, there are 3 types of ovarian cancer: epithelial tumors, germ cell tumors, and gonadal sex cord tumors. So for the purpose of this presentation, the basic principles when we are going to discuss, as generally, it's going to be for epithelial ovarian cancers. And 90% of them are, as they constitute 90% of all malignant tumors. The most common is the serous variety, and the other varieties would be mucinous, endometrioid, clear cell, transitional cell, or mixed. Apart from the high-grade malignant epithelial tumors, there are low-grade and borderline tumors also. Now, as the topic on fertility sparing surgery has already been discussed, the low-grade varieties, borderline epithelial tumors, germ cell tumors, and gonadal sex cord tumors all constitute as candidates for fertility preservation surgery. And so their management is slightly different from the high-grade epithelial tumors, which we are going to discuss now. In the pre-treatment evaluation, as we have already discussed, of course, the history, physical examination, the imaging, which can constitute a contrast abdomen pelvis scan or an MRI or a PET scan in the form of functional imaging, tumor markers. These are all done to evaluate the patient whether that is going to be a surgical candidate. Now, the most important thing is who should be performing the surgery for ovarian cancer. So whenever we have a patient of suspected ovarian malignancy, it is pertinent to refer it to a specialist in gynae oncology. Maximal optimal results are obtained when patients are operated in high volume centers with interdisciplinary collaboration. All the guidelines mention it, and there have been multiple studies. If the surgeries are performed by gynae oncologists, there are higher chances of complete cytoreduction, there are less complications, of course, there is improved survival, and there is, of course, higher chance of conformance to guidelines. If you want to quantify, there is almost a 30% increase in survival in patients with ovarian cancer. Now, going to the surgical principles, we are going to divide it into early ovarian cancer and advanced ovarian cancer. Irrespective of whether we are doing surgery for early or advanced ovarian cancer, our goal is that we have to remove the disease completely. Optimal cytoreduction and ultra-radical surgery. So for early ovarian cancer is basically stage 1 and 2, which means that you have an ovarian mass or disease which is confined to the pelvis. So mostly these patients are young, good biology disease, but can be, of course, high-grade epithelial tumors do present. So these patients are the ones which usually present in complex ovarian masses, and we take them up for exploratory laparotomy. And then on frozen section, the report comes as high grade or positive for malignancy, and then we proceed for complete staging surgery. So all these patients complex who have a high suspicion of malignancy, of course, should be planned in a setting where the frozen section is available. If the frozen section is not available, two-step procedures should be planned. So how do we proceed for surgery? Of course, it is going to be a midline vertical incision. That is what is recommended. We have to debulk the pelvic disease completely. And of course, we have to evaluate for occult disease in the upper abdomen. So on entering the abdomen, we have to collect the peritoneal cytology, or if cytus is present, before the manipulation of the tumor. Because peritoneal cytology upstages the disease and guides the adjuvant treatment. All peritoneal surfaces should be visualized. Inspection is very important in ovarian cancer because we have to remove all the disease and we can only remove what we are going to see. So a thorough inspection is the cornerstone of a good surgical effort for ovarian cancer. We remove the mass en bloc. We have to avoid the rupture of a yet unruptured mass, and that is the only certain approach for the diagnosis of masses. We send it for frozen section, we get a report of a high-grade malignancy. Then we proceed for complete staging surgery. We do remove both the ovaries and the uterus. We do the omentectomy. We do the pelvic lymphadenectomy and the para-aortic lymphadenectomy up till the level of the renal vessels. We remove any suspicious peritoneal disease and we biopsy all the suspicious adhesions. Now, the template for the pelvic lymphadenectomy in ovarian cancer or for any gynae malignancy is, of course, the bifurcation of the iliac arteries, the genitofemoral nerve on the lateral side, on the medial side, the oblated umbilical artery, on the distal end, the circumflex iliac artery, and on the floor, the obturator nerve. For the para-aortic lymph nodes, of course, we have to dissect up till the level of the renal vessels. The right ovary goes the right ovary drains into the paracaval and the interaortocaval nodes, and the left ovary drains into the para-aortic and the aortocaval nodes bang on below the renal vessels. So it's very important to debulk the lymph nodes between the inferior mesenteric artery and the renal vessels. 30% patients are upstage if we are doing a comprehensive surgical staging in a primary ovarian cancer setting. Whatever we have discussed is what all is recommended in the guidelines, all the international as well as the national guidelines. As we have already discussed, fertility preserving surgery is possible in a select group of premenopausal patients, and they have their own criteria. There is also a role of laparoscopic restaging and MIS in early stage ovarian cancer, which will be discussed in the next lecture. Then when we have done the procedure, of course, we have to document what all we have done. We have to mention the extent of the disease. We have to mention whether we have resected it completely or not. That is mentioned in the form of R0, 1 or 2. R0 means no residual disease, 1 means less than 1 centimeter, and R2 means more than 2 centimeter. Now, in early ovarian cancers, there are some cases where we can avoid doing lymphadenectomy because lymphadenectomy as a procedure carries significant morbidity, and therefore the decision to do a complete lymphadenectomy depends upon the patient factors also. But there are certain biologies in which we can avoid it, like the stage 1 expansile mucinous tumors, the low-grade serous ovarian cancer, the borderline cancer, the germ cell sex-cord stromal tumors. And fertility preservation, as we have already discussed, is, of course, can be done in some patients. Now, when we come to advanced ovarian cancer, the surgical principles are more or less same in early ovarian cancer. We have to remove the disease completely. The only major difference between the management of early and advanced ovarian cancer is that we only remove the enlarged lymph nodes because lymphadenectomy is not associated with survival in advanced ovarian cancer. Now, the issue in advanced ovarian cancer is that when should we operate? Either should we go ahead for primary debulking surgery, or if there is a high volume disease, whether we give chemotherapy, go for interval debulking surgery, and then give the remaining adjuvant chemotherapy. So the decision to operate actually depends upon multiple factors in advanced ovarian tumor. Of course, the patient factors are important because the surgery is going to be extensive. So the age of the patient, comorbidities, the performance status matters. The tumor-related factors, of course, extent and location of the disease. If the disease is located in areas which are non-resectable, we are not going to do it upfront. We are going to give some amount of neoadjuvant chemotherapy and then plan an interval surgery. And of course, the center-related factors, which mean the surgical training, the expertise, and the ICU setup, pathology, everything that is there in a particular center. So the two debates which are there in the management of advanced ovarian cancer are, of course, whether primary or interval surgery and how much disease should we remove. So there are so for a long time, primary cytoreductive surgery was considered to be the gold standard in management of ovarian cancer because many clinicians argue that it establishes a diagnosis and relieves the symptoms of the patient. It removes the bulky and necrotic tumors which have poor blood supply, and therefore the adjuvant chemotherapy works better. It removes the tumor cells which are in a slow growing phase, which might not be susceptible to chemotherapy or may be resistant to it. But the problem with primary cytoreductive surgery is that it causes high morbidity, longer surgical time, blood loss, and stoma. Interval cytoreductive surgery, on the other hand, gives the benefit that it allows the preoperative optimization of a patient who might not be fit for surgery in the first go. Then also it identifies a small group of patients which might not respond to chemotherapy ever. Then, of course, excellent responses can be seen in BRCA patients. And the most important thing is interval cytoreductive surgery minimizes morbidity and reduces the surgical time. And it can also avoid inadvertent bowel resections if the disease resolves with chemotherapy, and stoma can be avoided in these patients. All this has been proven already with multiple trials. Evidence is there that interval cytoreductive surgery is associated with less morbidity, and there is no significant differences in overall survival between primary cytoreductive surgery or interval cytoreductive surgery, as most of the clinicians believed before. Also, it was seen in multiple studies that the survival of the ovarian cancer patient is proportional to the amount of disease that we are removing during cytoreductive surgery. Still 2000s, most of the patients with upper abdominal disease were not being optimally debulked. But after 2006, there was a drastic change in the management of ovarian cancer. Ultra radical surgeries involving ultra radical resections of the upper abdominal disease, whether diaphragmatic stripping section, liver capsular deposit excision, Glissen's capsule removal, splenectomy, bowel dissections, they were all then considered a routine part of the cytoreductive procedure. And the goal was that we have to remove as much disease as possible and achieve an optimal cytoreduction that was a disease less than 1 centimeter. Now, a new concept of CC0 is there when the optimal cytoreduction would be considered as a disease of less than 2.5 mm. So, with every 10% increase in the amount of the disease removed, there was a 5.5% increase in survival in the particular cohort of those patients. And therefore, there was addition of this extensive upper abdominal surgery, and that showed improvement in survival of these patients with advanced ovarian cancer. So both the things, whether primary or interval and ultra radical procedures, should be done. TRUST trial has demonstrated that ultra radical procedures, along with even interval surgery, has very good survival outcomes. So, as of now, the practical approach is that in advanced ovarian cancer, if possible, we should consider interval cytoreductive surgery, give neoadjuvant chemotherapy so as to reduce the associated morbidity. So practically, if we have a low volume disease, we go for primary cytoreductive surgery. And if we have high volume disease, we go for interval cytoreductive surgery. How do we measure the volume? Of course, there are multiple algorithms which combine age, tumor markers, then the location of the disease radiologically, and then they predict whether we can resect the disease completely or not. If we have any difficulty, if we are confused whether we can reduce this optimally or not, there are laparoscopic staging that is available, the Fagerty scoring, which is the commonly used, in which we check for sites which can indicate inoperability, like omental disease, extensive peritoneal carcinomatosis of the small bowel, or extensive diaphragmatic disease or mesenteric disease, and then we go ahead with the surgery. So in any confusion, we put in a camera, we explore thoroughly, we take a biopsy, send it for frozen section, we score. Depending upon the scoring, we decide whether we go for primary or interval surgery. Again, the impact, there, of course, the amount of residual tumor impacts the survival in advanced ovarian cancer. So all the guidelines again recommend the same thing in cancer, that we have to remove the disease completely. The only difference between early and advanced ovarian cancer is that we only remove the enlarged lymph nodes. The other important thing in advanced ovarian cancer is that metastatic disease may not always mean that they cannot be reduced. For example, inguinal and axillary lymphadenopathy can be removed. Retropleural paracardiac or diaphragmatic nodes also can be removed. Focal parietal pleural involvement, isolated lung parenchymal metastasis, everything can be removed. Resectable intra-abdominal parenchymal disease includes splenic metastasis, capsular liver metastasis, single deep liver metastasis, depending on the location, can be removed. So we have to give the maximal effort as possible. The other important inclusion in the interval cytoreductive surgery group is the addition of HIPEC in these patients, that is heated intraperitoneal chemotherapy, that is given that has shown to improve the survival by around 12 months in patients who are undergoing interval cytoreductive surgery. And now it is become a part of standard clinical practice to offer this to patients. These are just the pictures.
Sorry to interrupt you, and your time is up.
Okay, so just the last slide is that when not to operate, there are certain criteria from which the most important is deep infiltration of the root of small mesentery. So the take-home message is that every ovarian cancer patient will require one good surgery, and adjuvant chemotherapy is not a compensation for a bad surgery. So a trained gynecologist at a high volume center with interdisciplinary collaboration is important. We have to remove the disease completely. Of course, participation in clinical trials improves the quality of surgery. And fertility preservation, as already discussed, we have to maximize the radicality in terms of ultra radical surgery, minimize the morbidity in terms of doing interval cytoreductive surgery whenever possible. And all of this ultimately improves the survival and the quality of life of the patient. So we have to remove, it's not how much we remove, but actually how much we are going to leave behind that will define survival in these patients. So thank you.
Very nice presentation, Vaishali. I think questions we will take in the end, but I want to ask you, what is your theory about, what will you think about doing this lymphadenectomy in early stage? Can we go for sentinel lymph node biopsy in these patients, early stage? Is there any role?
So no, there have been studies, but it is no, sentinel lymphadenectomy is not done in ovarian cancer because the lymph nodal supplies, as I already explained, right ovary is going to the inter-aortocaval, paracaval nodes, the left to the para-aortic and the aortocaval node. So it was not seen. Sentinel lymph node was not demonstrated to be reliable in cases of ovarian cancer. There has been a study, but it's not the standard of care.
Yeah, it's not, it's
There
still in
there
trial
are
setting.
trials which are
So not a standard
yeah,
of
trial
care.
setting. Yes, yes, ma'am. I'm just asking her what was her
Oh, yeah.
opinion.
Yes.
Yeah, just her opinion because she has covered everything, and it only that was not covered. So I just thought I will ask.
I think multiple institutes in India are also doing the trial on sentinel
Yeah,
lymph node.
yeah,
in
ma'am.
ovarian.
Even we are doing in interval setting as well as in primary setting. We are also doing some trials. So I
Yes.
was just asking her opinion on that. Otherwise, the presentation was excellent.
Yeah, thank you, Jyoti. I think we have with us Dr. Parag. So thank you so much for joining in spite of all your busy schedule. So I think I request Dr. Parag for his words of wisdom. Good evening.
Yeah, good evening.
This is the
Thank you,
sitting chairperson of.
Yeah, thank you, Bhagya. I'm not disturbing the flow, but then I'm in Chennai. We had one CME here, so I just finished it, and I thought I must join now. Vaishali, the presentation was excellent. I heard you for the second time in last 1 month, and this was also a very nice presentation. First of all, I would like to appreciate all the three conveners, Dr. Bhagyalakshmi Nayak, Dr. Harshad Parasnis, and Dr. Sarita Shamsundar, who've taken the responsibility of conducting this program. And when we were finalizing this program, we thought of these three because they are the hardcore onco people who've donned the oncology committee of Foxy, and then they have great experience in this field. So thank you, Bhagya, for chalking out a very nice program today. And I'm sure it's going to be a great learning experience. And thank you, Usha Shri, who's helping you today, coordinating the activity. Thank you.
Thank you so much.
Go on to the next talk, ma'am.
Yeah.
So our next speaker is Dr. Anbu Subian, ma'am. She is the consultant gynec oncology at KMCH Coimbatore. She'll speak on role of MIS and when to avoid it. Anbu, ma'am.
Yes, can I please share my presentation?
Yes, ma'am.
So the topic, thank you, Bhagya ma'am, for giving me this opportunity. It's great to be here this evening. The topic that has been given to me is the role of minimal invasive surgery in ovarian cancer, and also some circumstances when we have to avoid it. We all know that MIS use is increasing overall in gynecology, and that is reflected in its use in gynecologic oncology as well. We are not strangers to the fact that MIS is associated with very good perioperative outcomes in terms of intraoperative blood loss, reduced hospitalization, post-op recoveries, and adverse events. And maybe due to certain recent innovations and availability of technology, it is also becoming lesser and lesser expensive and therefore more affordable in different corners of the world. And therefore, there's been a huge uptake in MIS techniques in gynecology. What about gynecologic oncology and particularly MIS and ovarian cancer? Now, I'd like to cover these four domains where there is an interest in the use of MIS One of them is in the early ovarian cancer space, where it is being used for diagnosis and for staging suspected early ovarian cancers. Second is whether there is a suitability for upfront debulking surgery or following neoadjuvant chemotherapy in advanced ovarian cancer. Second thing is so this is basically to make a decision on whether the patient is going to go via debulking or towards NACT followed by interval debulking. Another space which is becoming very interesting right now, and we've got one RCT which has been published, is in actual post-neoadjuvant chemotherapy for interval cytoreduction. Most of us would have heard of the LANCE trial. So there's a lot of interest in MIS in the interval debulking space. And finally, for secondary cytoreduction as well. So let's look at the first domain, which is evaluation and staging and diagnosis of apparent early ovarian cancer. Now, for this audience, I don't need to particularly tell how you go about doing a laparoscopic procedure for an ovarian mass, because early cancers don't announce themselves. Sometimes we have very obvious criteria on imaging, say according to the IOTA adnix model, you could have an IOTA scoring of 5. You could have a solid nodule with high vascularity or an MRI, and therefore you've got a preoperative diagnosis or a suspicion of early ovarian cancer, but you still might want to consider MIS for removing this tumor and then confirming the cancer. So as far as feasibility is concerned, this has already been established. It shows comparable safety outcomes to laparotomy. It has postoperative recovery is excellent, and it may be particularly useful for younger patients because these are the ones for whom we are going to consider fertility sparing when the tumor is early. And this is all retrospective case series that has been published over the last 2 decades. What about the oncological outcome? There has been one trial by Valeria Galota from Anna Fagotti's group, which says that the outcome is actually equivalent to laparotomy. But this, again, is not a randomized controlled trial. Despite that, current Cochrane evidence says that there is no good quality evidence to help quantify the risk and benefit of laparoscopy for the management of early ovarian cancer in routine clinical practice. Now, we have to see that this Cochrane review was published in 2016. That's 9 years ago, but nothing much has changed in terms of the quality of evidence since then as well. So what are the main concerns? The concerns are intraoperative spill. We all know that when spill happens during surgery, it automatically stages the disease to FIGO 1C1. And in many cases, this may shift the patient from being potentially curable by just surgery to having to receive chemotherapy for the simple complication of intraoperative spill. So I'd like to quote this one big series, one of the largest series in the world, which is published by Koji Matsuo in 2020, who analyzed the trends in minimally invasive surgery. 8,000 patients were studied. He not only studied the association between MIS and rupture rate, but they also looked at survival in early ovarian cancer. And as much as 22%, so 1 out of 5 patients had a capsule rupture in early ovarian stage patients who underwent MIS. What this basically meant is also it had a detrimental effect on survival. The survival was least for, of course, open surgery and ruptured tumors, which were found, I think, intraoperatively ruptured. But when you look at MIS and non-ruptured tumors compared to MIS and ruptured tumors, there was a statistically significant difference in the 4-year overall survival. And the 2 independent factors which were associated on multivariate analysis was using MIS and larger tumor size, which brings us to the question, what size is safe? So what Matsuo's data shows is, if you look at the left corner of this table, it categorizes tumors as less than 2 centimeters, 2 to 4, 4 to 6, 6 to 8, and then 8 to 10, and upwards of 10. Now, if you look at 0 to 2, and it was taken as reference, ARR is the adjusted risk relative risk. You look at the last column on the right, it shows that for 0 to 2, the risk is 1. So if you take that as the reference risk, from 2 to 4 centimeters, the risk slightly increases to 1.1. But anything above 4, the risk is compounding to 1.2. At 4 to 8 centimeters, it is 1.446, and 8 to 10 centimeters, it becomes 1.74. So if you ask if there is a takeaway from this table, we conventionally look at cysts, which are tumors which are less than 5 centimeters, to be small size tumors, which can be safely put in a bag, avoid rupture and take out. And looks like this data point also reflects some sort of a similar guidance, where cysts less than 4 centimeters have an almost similar relative risk, and cysts 4 to 6 centimeters and above slowly start showing the increased risk of intraoperative rupture and upstaging of disease. So no size is safe, but if you had to look at a cutoff, I think 5 to 6 centimeters might be a reasonable size. Anything more than that, the patient should be counseled that there is going to be an intraoperative risk and upstaging. So is there any model to predict this? This was an interesting study, which is called the Loch Ness study, which looked at 151 patients. And interestingly, previous pelvic surgery was more seen in patients with non-ruptured tumors. An increased rupture rate was associated with larger tumor diameter. Again, here that's a recurrent risk factor, higher body index, but that was not statistically significant. And additions. If your MRI, if your CT scan is predicting that this tumor is adherent to the ovarian fossa or to bowels or to the Poucher-Douglas peritoneum, that might be an independent risk factor for predicting rupture, and you might want to offer open surgery as an option. Like I said, larger tumor diameter and additions to the ovarian fossa peritoneum in this study was independently associated with intraoperative cancer spillage, and a disease-free survival difference between ruptured tumors and a non-ruptured tumors were also detected, although overall survival remained the same in this study. The other significant risk that we're worried about is port-side metastasis. Now, as far as early stages are concerned, the recorded data is that the risk of port-side metastasis is actually only 1 to 2%. There's very controversial data points around this. Different studies have different rates. It increases in advanced disease. It increases with risk of with presence of ascites, and it is also said to increase with closed entry, with where the layers are not independently sutured, whereas it is reduced with the risk of the open method of entry, where each of the layers were sutured after completion of laparoscopic procedure. This is Ignace Vergote's paper, but this actually says that the risk of port-side metastasis was almost 20%, but all of these patients who were analyzed in this series were advanced stage patients with omental caking and ascites. So we can go with the risk of about 1 to 2% for early stage ovarian cancers. Therefore, just a quick recap: in early ovarian cancers, laparoscopy may be offered. We have very good feasibility data points, but you have to counsel the patient for risk of rupture, upstaging, and potential need for adjuvant chemotherapy. What does guideline recommend? This is the 2024 ESCO guideline, which says that MIS, where avoiding tumor rupture is priority, is still an acceptable approach for women with early stage ovarian cancers who wish to preserve their fertility. Coming on to role of MIS in upfront debulking surgery and to deciding between surgery versus NACT, we all have heard about the laparoscopic predictive model that was put forth by Anna Fagotti's group from Italy. What this basically looked at was assessment of very advanced disease like omental caking, diaphragmatic carcinosis, mesenteric retraction, bowel, stomach infiltration, superficial metastasis on the upper abdominal viscera, and then they came out with the total predictive index value. Vaishali's also already covered this. So these 7 parameters were scored. What it basically told was this laparoscopic assessment of advanced disease showed that a score of more than 8 predicts suboptimal cytoreduction with very high specificity. The probability of optimally resecting disease at laparotomy compared to laparotomy was equal to 0, and the rate of unnecessary exploratory laparotomy was 40% if this score is high. For a score of 4, or under 4, a complete cytoreduction could be obtained in 78% of the patients. So if we are in a doubt as to whether to rely on imaging and whether you might potentially be able to debulk upfront, it is good practice to put in a scope to come up with the scoring, and if it's a high scoring, to avoid debulking at that point, to send the patient off to neoadjuvant chemotherapy and then plan for surgery later. Whereas if the disease is less and the score is less than 4, it is useful to go ahead with cytoreduction. So some of the ongoing trials in this space are the lab OFCA trial. This is right now recruiting in Netherlands, and this is looking at whether laparoscopy can be added as a potential tool to diagnostic workup of advanced ovarian carcinoma patients. Now, coming up to whether it can actually be used to resect disease in advanced ovarian cancer patients. This is the initial study, a study again published by Anna Fagotti's group, which was called the International Mission Study. This was a study which looked at minimally invasive surgery after neoadjuvant chemotherapy. It had about 100 odd patients, 127 patients. This study basically showed us that advanced procedures could be achieved through laparoscopy, and about 90%, 95% of the patients who were recruited in this study were actually able to achieve complete gross resection. The team had done multiple procedures like omentectomy, paraortic lymphadenectomy, diaphragmatic stripping, and bowel resection. But we need to remember that these are high volume, highly advanced centers, and extrapolating this same evidence to smaller centers which operate on ovarian cancers is not recommended. As such, European guidelines recommend that centers which operate on advanced ovarian cancers need to be those which are operating this on a routine basis. The outcomes of patients who get operated in these centers are much better than patients who get operated in centers with low number of cases. So this is not a clear evidence for us to start doing interval cytoreduction. What followed this trial, though, is the LANCE trial. This was a small number study where about 49 patients were recruited to have minimal invasive surgery, and 51 were recruited to have laparotomy following neoadjuvant chemotherapy for stage 3C4, and they showed that the gross resection rates were comparable. So this again is a feasibility study. The numbers in this trial are low. Coming to ongoing trials, there are 2 trials which are happening, one for laparoscopy and one for robotic surgery in interval debulking space. No trials as such for primary debulking. The decision tree that one could follow is if a patient has advanced stage epithelial ovarian cancer and initial assessment of CA-125 and imaging done. If there's high tumor burden, then directly NACT is given, and we go in for assessment of patient's performance status and CA-125 and radiological assessment. If the surgeon feels that it is feasible to do MIS, then you can proceed with surgery in a proper setting. If not, open surgery remains the standard of care. Finally, a quick word about second look operation. Again, very small numbers of cases which have been studied. This was a paper that was presented in ESCO 2022. Again, the Italian group, they looked at whether minimal invasive surgery in the secondary cytoreduction setting was feasible. They wanted to compare perioperative and survival outcomes, and they did show that gross resection was achieved in more than 90% of patients. And the good kind of patients to operate on was patients who received NACT when the site of recurrence is limited, or what we could call is oligometastatic disease. If it's only lymph nodal recurrence, then it is possible to do, it is possible to offer a secondary cytoreduction. Obviously, as we know, minimal invasive surgery offers less post-operative complications and easy recovery, and that was reflected in this study as well. So to conclude, it's a very, very valuable tool. We all know that, but as far as ovarian cancer is concerned, the evidence is still very patchy. It can help minimize risk and improve personalization of care, but clear-cut evidence on oncological safety is yet to arrive. We might consider offering this as an option in very carefully selected patients after explaining all the risks and benefits. Thank you so much.
Thank you, ma'am. I request Anupama ma'am to comment on the talk.
That was absolutely wonderful, Dr. Anbu. You have covered the topic exhaustively and given us very clear-cut messages, especially in, ovarian cancer, where one must go in with the scope and where there is no scope for a laparoscope or robotic. And I must compliment all the three speakers for absolutely wonderful lectures today. So I think we can move on to the question and answer session, Dr. Bhagyalakshmi ma'am.
Yeah, sure. Thank you, Anupama, for being there. I think, Tushar, you can take the questions in the chat box, but we have time only for 2 questions. The
Yes,
rest
ma'am.
will request the speakers to answer it on the chat box.
So good evening, one and all. So question for Anjana ma'am. In germ cell tumor, which surgery is sparing surgery? And oocyte freezing role in malignancy? 2 questions for Anjana ma'am.
In germ cell tumor, as I have said, if the disease is unilateral, we should definitely go for a unilateral salpingo-oophorectomy. Even if there is and if the disease is bilateral, then in the bigger side, we should go for a salpingo-oophorectomy, and the smaller side, we should at least try to preserve a part of the ovary. We can do a cystectomy as the disease is very much chemosensitive, then and is usually curable by chemotherapy. And we should leave the uterus also in situ. And
Ma'am, oocyte freezing role, ma'am.
yeah, coming to
Oocyte
this,
freezing.
actually, the thing is, we might not know the pathology. So there is very much concern about the hormones affecting the ovary. The ovarian tumor might be chemosensitive. So there is a concern regarding whether it is going to aggravate the disease. And if you are approaching an infertility specialist and if you are trying to retrieve the oocyte, there is another concern of upstaging the disease also. So we have discussed many times with the IVF specialist where the concern is mainly about the hormone sensitivity of the tumor as well as whether we will cause a tumor rupture inadvertently. So this is the issue.
So Vaishali ma'am, 2-3 questions for you, ma'am.
Yeah. Tushar,
Role of
1 second.
peritonectomy.
Before we go to Vaishali, please give me 1 second. To add to what Dr. Anjana has told, that the take-home message should be that when we are doing a surgery in young girls, I think it's better to take a consultation from a reproductive medicine specialist. So I think actually that's where sometimes we are forgetting that, but I think we should counsel them before we take up for any surgery. Yes, Tushar, please go ahead.
Vaishali ma'am, role of peritonectomy.
So role of peritonectomy. So there is debate about complete peritonectomy or partial peritonectomy in advanced ovarian cancer. But as of now, the standard of care is only to remove the involved peritoneum. That is partial peritonectomy should be done.
And when to
if
not
the no
operate?
peritoneum is important, when to not operate, I think that was the last slide. But whenever we have disease which is unresectable, in the sense there is diffuse deep infiltration of the small bowel serosal surface or the small bowel mesentery, or there is diffuse deep infiltration of the stomach, duodenum, the head of the pancreas, or the middle of the pancreas, the tail of the pancreas can be removed, or we have multiple liver metastasis which cannot be resected, or we have the porta hepatic involvement of the hepatic artery, celiac trunk, multiple lung metastasis, brain metastasis. That is the root of the small bowel mesentery, because it has the important structures like the superior mesenteric artery vein, which if compromised will lead to the loss of the entire small bowel. So these are the indications of not operating. These indications have gradually reduced over the past 10 to 15 years as the evolution of ultra radical surgery for ovarian cancer has taken place.
Do you need complete parietal lymphadenectomy in stage 1?
It still depends on the resources in which people are working. So
Yes.
if the surgeon thinks that will not be able to do a complete surgery, so I think it's in those situations, I think you can better go for and your patient status, the surgeon status, the resources, and the patient status. So I think 3 things should be taken into account before you actually plan for a surgery. So once you think you will not be able to do a proper surgery, or the post-operative morbidity is going to be too much for the patient to handle, so I think then you can go for neoadjuvant chemotherapy and surgery. So people working in different situations actually. So you have to decide according to the situation in which you are working. Yes, Tushar, please go ahead.
Madam, do you need complete parietal lymphadenectomy in stage 1 ovarian cancer?
So yes,
Complete parietal.
yes, we that is the recommendation for early ovarian cancer. Complete para-aortic lymphadenectomy should be done. And as I mentioned, in 30% of the cases, it does upstage the cancer. And I also mentioned the indications where it can be avoided. So I'm talking of stage 1 high-grade serous ovarian cancer and invasive mucinous cancer, or maybe high-grade endometrioid cancer, but it can be avoided in the low-grade serous varieties, the borderline ovarian tumors, and of course the germ cell and the sex cord tumor. But the recommendation, the standard of care is a complete para-aortic lymphadenectomy till the level of the renal vessels.
Last question for
Yes,
you.
I think epithelial it should be done. So the take-home message is it should be done in epithelial and can be avoided in germ cell and the sex cord stomatitis. Yes.
Last question for Vaishali ma'am. 20-year age, nulliparous, stage 4 with gross ascites and lymphadenopathy. Means lymph node involvement and gross ascites. Should we go for surgery?
So in
20
stage 4,
years,
by far,
nulliparous.
we always go for neoadjuvant chemotherapy. And now after, as I mentioned, after the publication of the TRUST trial, I think we are going to send even stage 3 majority of the patient for neoadjuvant chemotherapy, because interval surgeries are associated with less morbidity and similar survival. So stage 4, there is no question of upfront surgery at all.
So you'll go for neoadjuvant. So last question for Anbu ma'am. So why more than 100 mm means more than 10 centimeter has a risk ratio of 1.19?
Unfortunately, the authors have not given an explanation for this. This is just looking into data, and they've tabulated all the parameters that they looked epidemiologically, including race and age, and looking at the size of the tumor. And this is the risk that they've come up with. If you look at the survival also, if you look at the survival curves, MIS with unruptured is followed by open with unruptured, followed by MIS rupture, and then open rupture. And they've not answered that as well. So I have no idea why it is like that.
Maybe ma'am, B rule, M rule, B rule stands for less than 10 centimeter, M rule more than 10 centimeter. Maybe less than 10 are benign. Maybe the
But
answer.
all of these are malignancies.
Yes, ma'am.
So these have
So
been
the
studied
study
in
was all on
malignant
malignant tumors.
malignancies. Yeah, and the risk of, and all of these were early stage ovarian cancers as well. So they just looked at, I think they must have traced back from early stage, like stage 1, looked at the malignancy report, and then went back, collected data, and looked at all of the factors that were recorded in this series. So this is from a database. So they've looked at the age, and they've looked at multiple epidemiological factors. They've also looked at the type of tumors, the size of the tumors, and they've come up with an adjusted relative risk. The authors have not addressed this particular factor. Unfortunately, I wish I knew it as well.
Thank you, ma'am. Thank you
I
all.
think thank you so much. Yeah, please go ahead. Thank you so much. Thank you so much, Chairperson.
Thank you, Dr. Bhagya. I'm in patience. I can't talk much. There's a lot of cross talk going on. Thank you for the opportunity and good presentation by all the speakers. It was great listening. There's a lot more to discuss, but I think short of time will stop here. Thank you again. Thank you all.
Thank you, ma'am. All speakers were very good and the presentations were very nice. Thank you for the opportunity.
Thank you, ma'am.
I think, Ambo, could you stop share? Ambo, requesting you to stop share. Thank you. I think we have Dr. Sarita Balirao with us. So welcome, Dr. Sarita. So Madam is the Secretary of ICOG. So are you there, Dr. Sarita?
Yes, I'm
Yeah.
there very much,
Welcome,
and I'm
welcome,
listening
welcome.
and I'm enjoying the deliberations. Thank you so much, Dr. Bhagyalakshmi, for arranging this. And I'm enjoying all the deliberations that are going on. You can carry on.
Thank you so much.
Yeah.
Thank you. Thank you.
So coming to our last session for the day, adjuvant therapy in ovarian cancer. Our chairpersons are Dr. Anita Thomas. The slides, please. Dr. Anita Thomas, she is the professor and head of Oncology.
Yeah, CMC Vellore.
CMC Vellore.
Next slide, please.
And next, Dr. Chitratara. Dr. Chitratara ma'am is gynec-oncology head of gynec-oncology in Lakeshore Hospital, Kochi. And the third chairperson is Dr. Ashok Padi, sir. She is associate professor in gynec-oncology, HPGIC. Our first speaker for the last session is Dr. Devabrat Borman. She is Professor HOD of Department of Gynec-Oncology, B. Barua Cancer Institute, Guwahati. He will speak on adjuvant therapy in epithelial ovarian cancer.
Is my slide visible? Can you see my slide?
Yes.
Yes.
It's a full screen?
Yeah, not full screen.
Okay. Now? Hello?
Yes, sir. Yeah.
It's okay now? Yeah. Okay. So at the outset, I would like to thank Bhagalakshmi ma'am for giving me this opportunity, and also I'd like to thank all the chairperson ICOG, Dr. Parag Benewale, then Dr. Sheila Mane, who is also there, and the coordinators of today's meeting, and also all the other office bearers of Foxy and ICOG, and also the chairperson of today, Dr. Anita madam, Dr. Chitatara madam, and Ashok, my friend. Okay, so let me start. Before I start, I just like tell you, as Bhagalakshmi ma'am has told me, that this is a certificate program. For basically, I'll be touching on the basic aspects of adjuvant treatment in ovarian cancer. So basically, what is adjuvant treatment? So now from the last 2 hours, we have been hearing about the ovarian cancer, and you know now how to diagnose it, when to suspect it is a malignant case, and when to operate. And the most important thing of surgery is that the quality of the surgery. The less you leave behind at the end of the surgery will determine how long the patient lives. And also important thing is that after doing this surgery, which is the primary treatment, we need to give something so that the disease doesn't come back again, to prevent recurrences. The treatment that we offer after the primary treatment is called adjuvant treatment. So in CA ovary, so what are the adjuvant treatments that are available? The most important part is the chemotherapy. We know the chemotherapy is the mainstay of adjuvant treatment for ovarian cancer. Along with that, we have hormonal therapy for some it's a subgroup of patients, and along with chemotherapy, now the targeted therapy in the form of bevacizumab has come up, and maintenance therapy in the form of immunotherapy, also bevacizumab in the form of maintenance therapy has come up, which I'll be discussing in short during the course of my presentation. Okay, so now you see the early and the late stage ovarian cancer. If you see, so in advanced stage ovarian cancer, which consists from 2B onwards, chemotherapy adjuvant treatment is a must, that we know now. For the early, a very fraction part of the patient, there you may avoid chemotherapy. Rest of the patients, you will require chemotherapy as a adjuvant treatment. We know now for early stage, a surgical staging is done, followed by adjuvant chemotherapy or observation, which I'll be discussing. And for advanced ovarian tumor, there are two ways to go around it. First is the primary debulking surgery, if you feel it is operable, and it may be, if you feel that I may not achieve full cytoreduction, then we can go ahead with the neoadjuvant chemotherapy. When we do something before the primary treatment, we call it neoadjuvant. And whatever is done after the primary modality of treatment, that is called adjuvant chemotherapy. So now, if you see the history of chemotherapy, father of chemotherapy, by Paul Ehrlich is known as the father of chemotherapy. He coined the term chemotherapy. And if you see the history from 1985, 80s, in the 80s, we started with the three agent, the cisplatin, doxorubicin, and cyclophosphamide. Okay, and then in 1989, cisplatin and cyclophosphamide took over. From 3, we came out to, that is the platinum first started with this, and platinum has changed the whole scenario. And this platinum component has remained till today as a part of this chemotherapy. Now, after this, in the year 96, paclitaxel came into the picture, and now cyclophosphamide is avoided. We started with cisplatin and paclitaxel. Then came the carboplatin. They compared with this study. I'll go through these trials in short. Then finally, 2003, we started with carboplatin and paclitaxel, and till today, for more over 20 years, this remained the gold standard, paclitaxel and carboplatin. Along with this, slowly slowly studies were done and came into the picture the monoclonal antibody in the form of bevacizumab, which is VEGF receptor antagonist. And slowly from 2020 onwards, there came the role of PARP inhibitors. Okay, I'll go in detail later on. So just as I have already told, paclitaxel and carboplatin remain the gold standard of chemotherapy. Paclitaxel is basically, it works on the M phase of the cell cycle. And carboplatin or cisplatin is a non-cell specific chemotherapy. These are two things just. And how it works, why we say that it has to be given every 3 weekly or weekly, the concept of tumor lock kill concept, which emphasizes that chemotherapy kills a constant fraction of cancer cells per dose, not a fixed number. And this explains the need for repeated cycle and combination therapy to achieve a cure. So now we say that in early stage ovarian cancer, we need to give chemotherapy in some group of patients, especially when it is suboptimal surgery. It is based on 3 important trials: the ICON-1 trial, the ACTION trial, and the GOG 157. In the ACTION-1 and the ICON-1 trial, they have said that chemotherapy in early stage ovarian cancer improved the progression-free survival and overall survival, especially in the suboptimal surgery group. And GOG 157, they told that for high-grade ovarian cancer, 6 cycles of adjuvant chemotherapy is used. Other histologies, 3 cycles may be sufficient. This is for the early stage ovarian cancer. Now, just in brief, if you see high-grade, these were basically as per the NCCN 2025 version, for high-grade ovarian cancer, for all stage, even in stage 1A, 1B, 1C, chemotherapy is advised. For low-grade or grade 1 endometrioid, stage 1A and B, you can avoid chemotherapy. You can go for observation, but in 1C, you have to give chemotherapy. Generally, it is a plus minus, observation plus chemotherapy, but chemotherapy is given. Clear cell carcinoma, stage 1A, you can observe. Some people have tried chemotherapy in these patients also, but you can observe. And in clear cell 1B and 1C onwards, adjuvant chemotherapy is administered. Just a little bit about the low-grade ovarian cancer, low-grade serous cancer. Their hormonal treatment you can try. Some people have tried with hormonal cancer with equal response. So if the general principle is that complete surgical staging is critical before deciding on adjuvant treatment, stage 1A, 1B, grade 1, grade 2, including clear cell mucinous low grade, often do not require chemotherapy, but 1C or higher, you have to give chemotherapy. Histology-specific management is increasingly emphasized in guidelines, moving away from one-size-fits-all approach. That is very important. Now, clinical decision-making, clear cell and mucinous, chemotherapy reserved for high-stage disease. Low-grade serous, hormonal therapy is an important option. Chemotherapy has limited role. And most important thing, in these early cases, whether you give chemotherapy, you put the patient on observation, it has to be a shared decision. You have to discuss with the patient, counsel them, and then discuss and then take a final call whether you put her on chemotherapy or observation. Now, I told you that how you evolve. So these are based on these 3 trials. Initially the cisplatin came as per the GOG 47. They showed that doxorubicin and carboplatin, when combined with cisplatin, it has given a very good response, and platinum has come into the picture since GOG 47. Then came GOG 111, where they tried to compare cisplatin cyclophosphamide, which was continuing. Paclitaxel came into the picture. Now they compared the cisplatin cyclophosphamide versus the cisplatin paclitaxel. They showed that cisplatin paclitaxel is better. So now cisplatin paclitaxel has continued. Then came 2003, GOG 158. They compared between cisplatin paclitaxel versus carboplatin paclitaxel, and now it was proved that carboplatin paclitaxel is less toxic, easier to administer, and not inferior to cisplatin paclitaxel. So carboplatin paclitaxel is the gold standard as of now. Now, how frequency and how many cycles? So paclitaxel carboplatin dose I'll tell just in the subsequent slide. We know that clinical trial as per the ICON and GOG trial, they have established that paclitaxel and carboplatin is given every 3 weekly for 6 cycles as the gold standard. And this has continued till now. The same principle we are following every 3 weekly for 6 cycles. The concept of dose dense chemotherapy, people tried with giving instead of 3 cycle, 3 a week, they started, people have started giving in every week and see what happens. So two important trials, the Japanese group, the JGOG 3016 trial and the MITO7 trial. These are two important trials where they have shown, the Japanese group has shown that dose dance has a better survival and is a novel standard of care. Whereas the MITO7, the European group, they could not see any PFS or OS benefit. Patient tolerated the weekly chemotherapy better with lower grade, grade 3, grade 4 neutropenia and thrombocytopenia, but there was no OS and PFS benefit. In Indian context, I could find this study. It was done from the Bhagyalakshmi Madam's institution, Acharya Hariyar, and the Aligarh Muslim University. They have shown that it is effective and feasible treatment option in neoadjuvant setting in patients with advanced ovarian cancer with good response rates and acceptable toxicities. We also in our institute try to give it to some patients where who are a bit weak, who we feel cannot tolerate the 3 weekly dose, maybe because these weekly doses are given in a smaller quantity, the dose is smaller, so they may they tolerate these doses. So in those, sometimes we try this also, but the standard guideline is that 3 weekly paclitaxel plus carboplatin regimen remains the default first-line approach, with dose dense considered selectively based on patients, factors, and institutional practice. That is important. And another important thing is that if you are starting with dose dense chemotherapy, these patients should be around because they have to come every week for the chemotherapy. So that is also important thing. Some patients stay a long distance from the hospital, then those patients, it is better to give 3 weekly chemotherapy. Now, just one slide about this intraperitoneal chemotherapy, because we know that adjuvant chemotherapy means anything that is done after the primary surgery. So this is another, the intraperitoneal chemotherapy concept has come. Initially it started with the normothermic chemotherapy. Now, of course, the heated chemotherapy, few trials have shown good results, particularly in the IDS setting. So intraperitoneal chemotherapy, initially when it was started, it was just normothermic chemotherapy. There were two trials, GOG 172, which showed a good PFS and OS significantly improved in the intraperitoneal regimen, whereas the GOG 252 did not show any benefit. So it was conflicting here. People stopped using this intraperitoneal normothermic chemotherapy, but of late, again, it has come into the picture. There are few trials currently which are undergoing on normothermic intraperitoneal chemotherapy. They are trying to see with heated in comparison to the heated chemotherapy, that is high peg. So now another thing which has started along with this paclitaxel carboplatin is bevacizumab and PARP inhibitors. Now this bevacizumab is a monoclonal antibody, which is basically it is a VEGF inhibitor. They block the vascular endothelial growth factor A with cutting of the blood. We know that for any tumor formation, there's a new vascularization. This cuts off the blood supply and slows the progression. The basic thing is this. And PARP inhibitors, we know that PARP inhibitors, this PARP enzyme, they fix the DNA damage, and PARP inhibitors block this repair. And in BRCA mutated cancers, this forces the cancer cells into lethal DNA damage accumulation. This is how this PARP acts. So this bevacizumab, if you see, as I've already the monoclonal antibody, the dose that we give is 7.5 to 15 milligram per kg every 3 weekly. Complication is basically hypertension. In those cases, you cannot give. Delayed wound healing. That is why if you are trying to give bevacizumab in the NACT setting, then on cycle 3rd and cycle 4, that is the one cycle before the IDS and one cycle after the IDS, you have to stop it temporarily, the bevacizumab, and give only paclicarbo. And on 5th cycle onwards, you start again with bevacizumab. This is done along with the chemotherapy. And once the chemotherapy stops after 6th cycle, then you start maintenance bevacizumab for up to 12 to 15 months, depending on the whatever your institute protocol. Then the proteinuria, bowel complications, bleeding, and up to 3-4 more slides. So these are the 2 trials where they have shown that there is a very good response with bevacizumab. And PARP inhibitors, as I've already told, this is how it works. Basically, the cancer cells, this is basically used in the BRCA mutations. The cells have this defective HRRA. So the blocking the PARP removes their backup repair system, results in this synthetic lethality. So this is the 2 trials. Based on this, we give now olaparib, basically in the BRCA mutated patients, and this Paula trial have shown us that we can add this along with olaparib, along with bevacizumab, and it has come into the NCCN recommendations for maintenance therapy. So bevacizumab part is now recommended as per NCCN guideline, even in the first line setting at adjuvant maintenance therapy. So this is just these trials. The clinical, just few clinical things. The carboplatin, the dose is 450 to 600 milligram administered over 30 minutes. It is administered with 5% dextrose mostly. Common side effect is
Sir, your time is up.
yeah, just 1 minute. That the dose calculation. This is how we calculate.
He'll wind up. Don't worry.
Yeah. So paclitaxel, one important thing, paclitaxel has to be given in glass bottle. That is important. Otherwise, it gets a there is some leaching effect with the plasticizer and the dose. These are the things that you should do pre-medication. And this 3-hour infusion, studies have shown it's always better to give 3-hour infusion. So thank you so much.
Thank you. Thank you, Dr. Barman. That was, as usual, a fantastic talk covering all aspects from the history of chemotherapy in early to advanced ovarian cancer, and including the importance of weekly and 3-weekly regimens. Also going on to do an elaboration on maintenance therapy, covering from the history to the current. Excellent talk, Dr. Barman.
Thank you, madam. So I'll stop sharing.
Dr. Barman, I have read all these things for the interview at RCC long time back.
Yeah.
After that, I'm recollecting these things down.
I thought Bhagalaxmi was specific that you speak
Locally
about the
Bayesian
basic.
theory.
Dr. Devabrata.
Yeah.
Barman sir, how are you?
I'm
so that's
fine.
a excellent presentation.
I
We have
think,
covered
sir,
all
please
the aspects.
stop share.
Yeah.
Stop share your screen. Yes.
Yeah.
We'll move on to our next speaker then.
Yeah. Thank you.
Our next speaker is Dr. Biswajit Das. He is Professor Gynec Oncology, HOD of ACTREC and Tata Memorial Center, Mumbai. He is going to speak on adjuvant therapy, non-epithelial ovarian cancer.
Good evening, all. Am I audible?
Yes.
Yes.
At the outset, I'd like to thank the conveners of the ICOG, especially Bhagya ma'am, Dr. Sarita, and others, and of course the ICOG office bearers, Dr. Parag, Dr. Sarita. Your chairpersons, my talk is on adjuvant therapy, non-epithelial ovarian cancer, and I would like to keep it simple, knowing it's a course for it's a certificate course of ICOG. The contents will be the germ cell tumors, sex stromal tumors, and metastatic tumors, and the adjuvant treatment in this setting. Basically, this talk will be based on guidelines. What we follow, the European guidelines and the NCCN guidelines. Coming to the germ cell tumors, they constitute around 10% of all ovarian cancers, and malignant germ cell tumors, they occur in young women, and they represent 5% of all ovarian cancers, and 80% of the pre-adolescent malignant ovarian tumors are germ cell. This is the FIGO staging. I will not tell it detailedly because I think it had been discussed earlier. This is important because for all adjuvant management, whether it's epithelial or non-epithelial, the FIGO staging is important to learn and remember. So coming to the classification of germ cell tumors, they are dysgerminoma, yolk sac tumor, inguinal carcinoma, non-gestational choriocarcinoma, mature teratoma, immature teratoma, and mixed germ cell tumor. Coming to the management of germ cell tumors in general, dysgerminoma is the most common malignant germ cell tumor, and after a fertility sparing surgery, so fertility sparing surgery can be done in all stages of germ cell tumor. Some form of fertility sparing can be done, and it is the aim usually in young women. And for stage 1A, that is the tumor confined to ovary, it should be treated by surgery alone. 1B onwards, chemotherapy can be given, and B is the commonly used regimen.
Vishwajit, can we
Coming to
do
the
something
immature
about
teratoma,
there's a little breaking of your voice. So can we come closer to the device or maybe
hello, yeah, I'm closer to my device. Actually, I'm connecting from my. Okay, so coming to the immature teratoma, so these tumors are they contain typically the immature neuroepithelium, and stage 1A, grade 1, it's important. Grading is important based on the amount of the immature epithelium, neuroepithelium in these tumors. And patients with stage 1A, grade 1 immature teratoma, they do not require further adjuvant management. So these are after the fertility sparing surgery is done. So adjuvant therapy is needed for 1A to 1C, and in the higher stages, 1A to 1C, grade 2 to grade 3 immature teratoma, and in higher stages. So the BEP is the commonly used regimen again. For the yolk sac tumors, they are rapidly growing tumors. It's important once you diagnose the yolk sac tumor, should have to either do surgery or start chemotherapy, whichever is feasible or whatever is the plan at the earliest, because they're very rapidly growing. And all patients of stage 1 yolk sac tumors are treated with adjuvant chemotherapy after surgery. Active surveillance is usually an option in properly staged tumor, but its policy is not widely accepted. Again, BEP is the regimen. For advanced stage and recurrent germ cell tumors, fertility sparing surgery should be considered even in advanced stages for young patients, and the aim of the surgery is gross tumor debulking. But it's important not to mutilate, not to do mutilating surgeries to avoid delays in the post-operative chemotherapy. If the woman is postmenopausal and fertility is not a concern, hysterectomy, salpingocectomy is the option. And for them, as I told earlier, BEP regimen is followed. Important is that the BEP stands for the bleomycin, etoposide, and platinum. And for older age women greater than 40, usually, and with young patients with pulmonary problems, pulmonary toxicity, pulmonary diseases, bleomycin is omitted. So you give either 3 cycles BEP or 4 cycles EP, or you give 3 cycles BEP and 4 cycles is usually a omit bleomycin. Platinum sensitive relapse, combination of platinum is again used, and they can be combined with paclitaxel or gemcitabine or as salvage therapy. And a high dose chemo with autologous stem cell support may be used for recurrent ovarian germ cell tumors. I think the NCCN also states the same thing. As you can see, as you can see, the stage 1A, grade 1 immature teratoma, they can be observed, and rest all for your remembrance, you can remember that they all require chemotherapy. Now, the schedule of bleomycin is 30 units IV per week, and it's combined with etoposide 100 milligram per meter square daily for day 1 to day 5, and cisplatin 20 milligram per meter square day 1 to day 5 again, and it is repeated every 21 days for 3 cycles, as I told, or for 4 cycles for poor risk, but the bleomycin is omitted usually in the 4th cycle. The toxicity, most important toxicity for bleomycin is pulmonary toxicity, and fatal lung toxicity can occur in around 1%. The other toxicity of this regimen is there is a rare chance of a AML or a myelodysplastic syndrome, which can occur in 0.2 to 1% of the patients, although it's rare, but it's fatal. And usually etoposide is the agent that is implicated for this. Other than that, there can be neuropathy, the Raynaud's disease, the tinnitus, high tone hearing loss, monodal dysfunction, hypertension, cardiovascular disease, nephrotoxicity, osteoporosis. But it's important to remember that most patients will resume normal ovarian function and childbearing is usually preserved. Radiation, germ cell tumors are very radiosensitive, but radiation therapy is no longer used as a primary treatment. They can be selectively used to treat recurrences, if at all, but it's very selective case to case. So chemotherapy can be given in second and third trimester in the same doses because I think they don't cross the placental barrier. So they can be given in second and third trimester as for the non-pregnant women. Now for advanced disease, the germ cell tumors would present as an advanced disease. So in those patients, you can give a NSCT, neoadjuvant chemotherapy followed by fertility sparing surgery, and then you can do a optimal cytoreduction. And it is there is a study from AIMS. Now, how to do active surveillance? So most of the germ cell tumors, usually the dysdominomas, they recur in the first 2 years. The first year is the most vital. So it's important to have a close follow-up for the first 2 years with a clinical examination, radiology, and a serology. So for serological tumor markers, AFP is used for the Yuck tumors, beta CG for choriocarcinoma, and LDS for dysdominoma. But there can be a combination of all these markers can be raised because many times it's a mixed germ cell tumor as well. So important to do a clinical examination, radiological, ultrasound, and tumor markers for every 2 to 3 months for the first 2 years, then 6 monthly for 5 years, and yearly after that. For recurrent disease, dysdominoma, they usually recur in the retroperitoneal lymph nodes. And for them, the treatment can be surgery or again chemotherapy, which is BEP or TIP. Immature teratoma, important aspect to remember is that there can be a growing teratoma syndrome due to the mature component of the immature teratoma can be associated with it. And for them, chemo is ineffective. So surgery is the treatment. And there is a condition called gliomatous peritonei, where there can be mature glial elements over the peritoneum, which can again be treated with surgery if required, and prognosis is good. Embryonal rare tumors, the embryonal carcinoma, BEP, choriocarcinoma, similar to choriocarcinoma of the uterus, methotrexate-based regimens, or BEP, polyembryoma, again BEP. So mixed germ cell tumors, 2 or more germ cell components, they can occur together, and its most frequent combination is the dysgerminoma with a Yuck tumor. Now coming to the second part of the talk, the sex stromal tumors, they are the rare neoplasms, around 3 to 5%, and they present with endocrine manifestations. Most common is the granulosa cell tumor, and usually, unlike the germ cell tumors like dysgerminoma, which can be bilateral, sex stromal tumors and steroid cell tumors are unilateral, and they can occur in a wide range of age. This is the classification, WHO classification. You can get it over the net. So it's pure stromal tumors, pure sex tumors, mixed tumors, and mixed sex stromal tumors. The pure sex tumors are the adult granulosa cell tumors, the juvenile granulosa cell tumors, Sertoli cell tumors, and sex tumors with annular tables. Some facts. It's important to learn that granulosa cell tumor usually is a low-grade malignancy, and they may secrete estrogen, so it's associated with sexual precocity, seen in women of all ages, and there are adult and juvenile types which occur in younger age. It can be associated with endometrial hyperplasia or endometrial cancers. They usually are stage 1 at diagnosis. Fertility sparing surgery, that is unilateral salpingo oophorectomy, is feasible. and they are known for late and repeated recurrences. So they can recur many times, and up to recurrences have been reported till 30 years, and most of the time they would require surgery if feasible. Usually because they're less chemosensitive. And FOXL2 mutation is an important mutation in the adult granulosa cell tumor, inhibin B and AMH as the tumor markers. So similarly, stage 1A, that is confined to one ovary, stage 1A granulosa cell tumor does not require any adjuvant therapy. So adjuvant therapy should be considered for juvenile granulosa cell tumors, stage 1C, and adult granulosa cell tumors 1C2 to C2 onwards. Basically means if there is a intraoperative rupture, it's a 1C1. For adult granulosa cell tumor 1C1, you can omit chemotherapy. But for a juvenile, it's you have. I mean, there is a thought that you should give chemotherapy in these patients. So platinum-based chemotherapy again is a treatment. So ESMO says it's the BEP, and NCCN says it's paclitaxel and carboplatin. But usually, if they occur at a older age, because they can occur in a wide range of ways, paclicarbo is preferred over BEP. Alternates are the EP, the CAP, the cyclophosphamide, doxorubicin, cisplatin, or a platinum agent alone. So for advanced stage tumors, debulking surgery remains the most effective treatment. Median time of relapse is around 4 to 6 years, and it's the pelvis or the peritoneal cavity, the site of relapse. As I discussed, the platinum-based chemotherapy, BP, paclicarbo, they are the regimens that are usually used. Important to remember, they are hormone receptor positive. Progesterone receptors is usually positive, almost 100%. And their hormone therapies can be used in these tumors, like leupride, letrozole, anastrozole, and BAF is investigational. Coming to the sertolilitic cell tumor, they occur in third and fourth decades of life. And if they have got a poorly differentiated tumors, they may behave aggressively. They typically produce androgens, and virilation is there, but still fertility-sparing surgery can be done. So post of chemotherapy is needed for stage 1, even for stage 1 poorly differentiated tumors or with heterologous elements. If the tumor contains heterologous elements, you have to give chemotherapy. They don't, it can avoid. And BEP is the most commonly used regimen again. Now this is the NCCN. It says the same thing. Except
sir, your time is up.
Another 2 minutes, I'll wind up.
Yes.
Yeah, let me know before 2 minutes. It's better for the speaker to wind up. Okay. So this is the NCCN guidelines for all the therapy regimens that are used. As you can see, there is a role of immunotherapy that can be used for the MSI high germ cell tumors with tumors with high tumor mutational burden. So rare tumors are the SCOT. SCOT is small cell carcinoma of ovary with hypercalcemic type. They are present with young age, bilateral, aggressive, and paraneoplastic hypercalcemia is common in these tumors. And they are treated with multimodal approach, require surgery, chemo, and radiotherapy. Fertility and hormone replacement therapy for oocyte is an option. It has been discussed. And HRT may be used safely for germ cell tumors, but for sex-cut stromal tumors, because they are ER/PR positive, HRT should be avoided. Other metastatic tumors can be from the gynec organs like endometrium and cervix. They can be Krukenberg. They are usually mucin-filled signatoring cells from the stomach, breast, and colon. And others like melanoma and carcinoids can also, they present as non-epithelial tumors, and treatment is based on the primary. Thank you.
Dr. Vishwajit, you have covered extensively. You have covered.
Thank you, madam.
It was a good topic. But the only thing that I would like to mention few points. When you classify the germ cell tumors, it is better to, because it's not written in any books, to classify it as dysseminomas and non-dysseminomas, just like seminomas and non-seminomas. Probably that is, and with the chemotherapy, and it is shown that you are not only a good surgical oncologist, gynecologist, and you are a good chemotherapist also. Good chemotherapies. And cure and active surveillance became possible with only chemotherapy, adjuvant chemotherapy in germ cell tumors, and it's a good coverage of all this because it is a vast topic. In 15 minutes, it's difficult to cover it.
Thank you, madam. You can take any questions at the end.
Yes, please stay on. So I think we can go to the next talk.
Our next speaker is Dr. Nisha Singh. Please share her CV slide.
Please share madam's CV. Share.
Madam is Professor and Head of Department of Gynec Oncology in King George Medical University, Lucknow. She is going to speak on treatment of recurrent ovarian cancers. Nisha ma'am.
Yeah, you have to unmute. Team ICOG is tired at the end of the session. Please unmute Dr. Nisha.
She is co-host, ma'am, already.
Nisha, I think you have to unmute yourself.
I think she's
you
not
do it?
able to unmute. She's not able to unmute. Gauri, can you unmute Dr.
Yes,
Nisha,
ma'am.
please?
Yeah,
I
I've
think now,
requested, ma'am.
yeah, now I'm done. Thank you so much. Good evening. So I'll just share my screen. Can you see my screen now?
Yeah, perfect.
Yes, we can see.
All right. So, very good evening to all. The topic that has been given to me in this ICOG certificate course is Management of Recurrent Ovarian Cancer. And I'll be going through this, talking about the incidence, the characteristics of the recurrences and the types, what are the diagnostic criteria, what is the importance of surveillance, and treatment options for recurrent ovarian cancer, including the role of secondary cytoreductive surgery, some points about the targeted therapies and the hormonal therapies, and these are my references. So, when do we define that it is a recurrence? So, occurrence of the disease after complete response or remission after the initial treatment. So, there has to be a disease-free period, and then it will be called. So, the primary treatment response is classified as complete response when there is no evidence of disease on imaging and the biomarkers are normal for at least 6 months. It is called partial response if there is reduction in the disease burden and biomarker level, but not the absence or the normalization. So only when there is a complete response for about 6 months and then we see the disease, we actually call it a recurrent disease. Risk of epithelial ovarian cancer recurrence as per the Ovarian Cancer Research Alliance is overall it is about 70%. But if you see stage wise, in stage 1, the recurrence would be about 10%, except 1C3 where it would be about 30%. Stage 2, it would be about 30%. And stage 3 and 4, it is very high, 70% and above. The mean 5-year survival rate following the diagnosis of any recurrent epithelial ovarian cancer is less than 10%. So this is a disease which actually, whenever it comes back, we are all worried. The timing of recurrence, if you see among the advanced epithelial ovarian cancer, 75% of the clinically complete responders and 50% of the pathologically complete responders, they would recur with a median time of 18 to 24 months. So it is actually the first 2 years which are very important, that you have to see to it that if there is a recurrence, you catch it fast and then treat it. Site of recurrence, usually the first relapse would be in pelvis or abdomen in about 70% patients. And there is no difference in the first recurrence site between early and advanced stage cancer primarily. Now, this is an important slide. we need to understand that what is the classification, depending upon, because we all know, you have heard in the previous lectures that epithelial ovarian cancer is treated by the carboplatin paclitaxel. So it is platinum-based therapy that is given to all cases of epithelial ovarian cancer. So when the recurrence happens, it has to be seen whether it is a platinum sensitive or a platinum resistant. So previously we were just having these two classifications in 1992, while the one that is currently considered the platinum refractory is when the interval period is less than 1 month. So it is like the patient is actually not responding, and there itself you need to treat. It's only when it is within the 6 months that you call it a platinum resistant. But when there is a good gap of 6 months and then it happens, then it is a platinum sensitive, potentially platinum sensitive. After 12 months, it is a platinum sensitive clearly. So this is what normally is being followed. And based on that, we have the treatment protocols that we get. So how do you diagnose? So we know that there is a surveillance system. I'll just show you in the next slide. So you have to follow the patient, and what you have to see is the symptoms. If she is coming back with any abdominal distension, bloating, or there is pelvic or abdominal pain, again, satiety, nausea, bowel habit changes, frequency. I mean, the symptoms which she used to have when she initially presented. Then also the examination findings, if you're finding a mass, if there is ascites, if any lymph nodes are palpable, respiration problems like suggestive of pleural effusion. So you have to look for those. So a complete clinical examination is required on every surveillance visit. And then when there is any suspicion, then an imaging has to be added, or at some interval, say 6 months or 1 year, that which we usually do with an ultrasound to start with, where you may see some um, solid lesions with regular margins. You may see ascites. You may see some retroperitoneal lesions, which may actually not be picked up in the ultrasound, but a contrast enhanced CT would pick that up, which will have a better sensitivity and specificity compared to ultrasound. MRI has a further better diagnostic accuracy compared to the CECT. And whole body MRI can also be done, or nowadays, because with the availability of PET CT, if we are suspecting distant metastasis or the symptoms are suggestive of recurrence in sites other than the abdomen and pelvis, then definitely a PET CT is better. And otherwise also, if you're finding at one place, to rule out other places and hence to decide the treatment, it is better whenever you're suspecting recurrence, you better do a PET CT so that you know which other sites that need to be addressed. The biochemical markers are added whenever there are any clinical features. Routinely doing the markers on every visit is not advocated. So you can do depending upon what was the primary histology. So mostly if we are talking about epithelial ovarian, it will be the CA125. But if it was a mucinous or a germ cell, the marker will be whatever marker was raised initially, the same will tell you about the recurrence also. So this is the surveillance protocol in ovarian cancer treatment after the completion of treatment, surgery plus chemotherapy. So usually 2 to 4 months in the first 2 years, and then 3 to 6 months in the next 3 years. And after 5 years, it is annually. And as I said before, on each visit, taking the history, asking her the symptoms, doing a complete physical examination, and looking at any side effects of the chemotherapy that has been given is important. Tumor markers and imaging have to be added as and when required. And so if everything is going all right, you can just continue the routine surveillance. But at any time, if the marker is raised or there is a clinical suspicion or imaging is showing and recurrence is found, it has to be treated. Then there is a term known as the biochemical recurrence, and that is when there is a rise only in the marker and not in the, there are no features of recurrence in the imaging, and symptoms also are not there. So because if somebody does a marker on every visit without any features, sometimes these things may happen. Now, one thing is that saying that the marker is raised, what we do in the primary disease is when we say 30 or 35, units per ml. But when you are talking about recurrence, then it is the twice the upper of the normal documented is taken as abnormal. So it is not the 35 units per ml, but it is more than it is twice the normal, or wherever the patient had the nadir value, that is the minimum, and then twice of that, and when it is on at least 2 occasions. So that is how we take this into consideration if there are no other features. These are 2 studies that I have just quoted here. This was in Lancet in 2010, and it was a prospective RCT, and it showed that randomizing people to early treatment or delayed treatment just based on this, they said that in the absence of radiographic or clinical findings, labeling biochemical recurrence can result in artificially shortening the progression-free interval, because you start treating early, and this may cause some patients to be inappropriately labeled as platinum resistant. So they concluded that to avoid starting the second-line chemotherapy in asymptomatic patients whose only evidence of recurrence is the CA-125 in the absence of radiographic findings, and reserve the platinum-based therapy for the development of radiographic or clinical signs. While another study in 2013, they found, it was a prospective study also, and they actually found that if you use this CA-125 level, it can guide you. So maybe if you find a rise, you can call her on more frequent visits and you can pick up the disease earlier. So that is how we could use this rather than jumping into treatment straight away. Now, what are the goals of treatment in recurrent ovarian cancer? We understand that relapsed disease is generally incurable, means completely removable. It may be difficult to do that. So the goals of the treatment are prolonging the survival of the woman, delaying the progression, and control the disease-related symptoms. So give her some good quality of life and minimize the treatment-related symptoms also. So, and what are the issues that come up? So, it obviously therapy will be based on, and the results will also be based on the tumor biology and histology. What was the treatment-free interval, and number of previous cycles that she needed for the primary therapy, any toxicity from the prior therapy, what was the use of any growth factors, transfusions, did she have any complications, the neuropathy, what was the volume and site of disease, that is actually the stage of the disease, symptomatic urgency, what is there today, and what is the performance status of the patient, and what is her choice. Patient preference is also important in this. So overall survival is related to these things: the FIGO stage, residual disease, and time to recurrence, site of the relapse, and the treatment at the recurrence. So based on all this, we will take up the first group, that is the platinum sensitive, which is clearly 6 to 12 months of complete remission, and then the disease is coming up. Then in these cases, a second line chemotherapy has to be given. The platinum sensitive will have can be given platinum again. And the second role is of surgery in limited cases. I'll just talk about them. So when we say platinum sensitive disease, so these patients, because they have had a good remission after the initial chemotherapy, so they can be given the same chemotherapy again, and they can respond to that. If there is radiological or clinical relapse and it is limited, that is, it is localized and it seems to be completely removable, then secondary cytoreductive surgery is to be done. But if there is a biochemical relapse where there is no radiographic evidence of the disease, then you can delay the treatment until that appears, as I said previously also. Or and when it comes, you can, if it is a diffuse disease which does not seem to be removable, then the patient has to be taken up on carboplatin platinum chemotherapy. So that is for the recurrence. There are some other regimes that are available in case the patient does not respond to it. Then in those cases, there could be the combinations like carboplatin gemcitabine with bevacizumab. There could be carboplatin liposomal doxorubicin. So this is the chemotherapy regime. And there are other targeted therapies, hormone therapies also, which I think it is a very busy slide to learn all this through this The only thing is that we have to go for, if they don't respond, then we have to go for others. Otherwise, in the platinum sensitive, we have to go with the platinum based therapy initially. And these are some of the trials that have been done, and they have been compared in this slide. You can see, so the various trials with carboplatin paclitaxel combination, then carboplatin gemcitabine combination, and with the PLD. So all have been done, and there are results of minor differences. You can say some differences in some months only that will be shown. So the most commonly used is still the carboplatin paclitaxel only. Now, for the secondary cytoreductive surgery, these are the various trials: the desktop 3 trial, the GOG 213, and SOC1, and the soccer and the loroxin trial. And the results that we have now, as I said previously also, especially the desktop trial has shown that if there is a disease which is limited to one area and it appears resectable, then the patient can be taken up and there will be benefit. But if it is incomplete resection and you take up the patient, or it is a diffuse disease, and then it will rather be a harm to the patient. So that is why we should think about all patients who have platinum sensitive recurrence. They should be counseled and the surgery should be taken up by experts in specialized centers only. Then talking about the role of HIPEC in ROC, as of now, HIPEC adding to cytoreductive surgery has not been proven to be beneficial in appropriately designed prospective studies. So the results of multiple RCTs on HIPEC in recurrent ovarian cancer are awaited. And until then, we cannot really say with clarity that we have to always add it. Then platinum resistant recurrence, that is when the disease comes back within the 6 months only. So in those cases, we have to go for non-platinum chemotherapy. So, and these are the cases where the response will not be very good, and you have to look up for the drugs that can be, other drugs that can be
Ma'am, your
given.
time is up.
Okay, I'll just bind up. This was
Okay,
the
ma'am.
second part only. So this is the list of drugs that can be used in the platinum resistant therapy. And for these cases, actually, the clinical trial enrollment is important because we are still working on this, and various drugs keep coming and showing some responses. And the targeted therapy can be given as maintenance therapy, where we have the PARP inhibitors and the anti-angiogenic agents, the bevacizumab and the PARP inhibitors. So that is the importance of maintenance therapy. So after recurrence, definitely a lot of drugs have come up that should be tried for that. So niraparib and then olaparib, rucaparib for maintenance. There are various trials. Some of them are ongoing. Some results we already have. And then the role of single agent bevacizumab is also there in platinum resistant ovarian cancer. I think I will just... Then there are some immunotherapy studies also, which although we do not have FDA approvals, but NCCN recommends, and a lot of, again, the trials are there which are working on this. The letrozole, long known drug, but the specific use that is there is and this is one of the meta-analysis that I have just put up. So responders have a significantly longer duration of response than tamoxifen, the comparative study. So it has role in certain cases. So to summarize, recurrent ovarian cancer is diagnosed through post-treatment surveillance protocol adherence, which is important. Clinical examination is important on every visit. Classification into sensitive and resistant, platinum sensitive and resistant is important. For the platinum sensitive, best treated with the CP regime, and secondary cytoreductive surgery only when it is a completely resectable disease. Platinum resistant disease recurrence will be treated by second line therapy, targeted therapy, immunotherapy or hormone therapy. These are the various options, and we still have to find the best options for them. Thank you.
Thank you, Dr. Nisha. I think that was
Good
very
evening.
difficult.
Yeah.
Sorry.
Good evening. Dr. Ashok here. So, good evening, one and all. At the outset, I'm thankful to the organizers and ICOG team especially Dr. Sharita, Dr. Bhagyalakshmi Madam, for giving me the opportunity to chair this session. Coming to the topic, actually, ovary cancer is one of the only ovarian gynecological cancer which is more prone for early recurrences, because unlikely endometrium and cervix, which the recurrence occurs later on, and recurrence are less compared to that of ovarian cancer. That may be, and again, it is the you encounter these recurrences. And Dr. Nisha, coming to Dr. Nisha covered all the aspects, starting from the types of recurrences, what is complete response, partial response, and he has also covered how to deal with the what is the imaging and how to deal this recurrences. Coming to this, there are so many trials like GOG 1213, this desktop 3, and this SOC1 trial, and they're given that. But the one thing is very important: the dictum or the key takeaways today is, if the first surgery is good, if you are achieved optimal reworking in the first surgery with no residual disease, these are, if that, even if there is a recurrence occurs later on, we can deal it properly. And there is again, these patients are very good so far their treatment is concerned for the recurrences. So thank you so much, Dr. Nisha, for this nice deliberation. So over to the organizer.
Yeah, I think Tushar and Usha, please take the questions first.
Yes, ma'am. Madam, question for Nisa, ma'am. Role of PET-CT in recurrent ovarian cancer.
So as I said, PET-CT is important because when there is recurrence, although clinically you are finding it in the abdomen or pelvis only, but it is better to do the PET-CT so that you know if there is elsewhere also, you know, whether surgery alone or the chemotherapy. It is always better to know where all the disease is, because there could be everything may not be clinically appreciable or just limited to the. I think it should be done.
Now, what is HIPEC? Means is
Dr.
yes,
Nisha, may I ask one question?
Yes, please.
Dr. Nisa, is it essential to go for PET-CT in all the cases of if you're suspecting any recurrent ovarian cancer, especially if you're planning for surgery, secondary cytoreduction?
Yeah, that is what I said, that secondary cytoreduction, you will plan that you think it is, but simultaneously, if there is more disease elsewhere, so you will have an idea. See, if it is available, it is better to get it done. You will have an idea that you might be falsely thinking that it is only this is it.
Yes.
You know.
So, madam,
Yeah,
or
so,
one question: what is HIPEC? Means when to give it?
okay, so actually HIPEC is the heated intraperitoneal chemotherapy, and in primary disease, after the neoadjuvant chemotherapy, when we do interval debulking surgery, it is recommended that if you add, there are studies that have shown that it will increase, it will give a better this thing. So if available, it should be. As far as doing it as a standard of care for recurrent carcinoma, still we do not have the guideline clearly. So that is why.
Ma'am, last question for you, ma'am. How do healthcare system in different country approaches maintenance therapy for recurrent ovarian cancer?
So definitely maintenance therapy is upcoming. We have results from various studies that maintenance, see, in BRCA positive cases like PARP inhibitors are very useful in different types. They are coming up, but it is, as you said, in the various countries and settings, the importance is about the cost factor. That is the most important, whether really the patient can take up or not take up. So that becomes a challenge. But the results are showing that maintenance therapy will reduce the risk of recurrence, and there will be a prolonged survival. But we are in the evolving stage. So things are coming up, newer drugs are coming up, and we can still not say it with only for few, like I said, PARP inhibitors for the BRCA positive cases, and some more that we can say.
Thank you, ma'am. One question for Bisway, sir. In growing teratoma syndrome operated because of the symptomatic, or it is because of the risk of malignancy? Means how much risk of malignancy present if you do not operate? Bisway, sir, please.
Yeah, so growing teratoma syndrome per se, if you tell, it is, as it said, it's due to the mature component which grows. So having said that, you always don't know whether the mature component alone is there or there is some mature component. So in areas of borderline operability when surgery is not straightforward or it requires a multivisceral resections. In those cases, what we do a biopsy to see if there are immature components along with mature components. If there are immature components, then chemotherapy can be given followed by surgery. But if the immature components are not there per se, they are only mature components, the treatment is surgery alone and you have to clear it or else it will again recur.
Thank you, sir. Last question for Debabrata sir. Already sir have answered. What is the argument given in low grade serous? Sir have already answered and shared in the groups. Thank you.
Yeah. Thank you.
Thank you. Thank you to the organizers for giving us this opportunity.
Thank you. Thank you so much.
Thank you. Thank you, Dr. Bhagya, Dr. Shastri Das. Thank you, all the organizers.
Thank you, ICOG, for giving us this opportunity.
Happy to see you all, Dr. Nisha.
Yes, yeah, sure.
See you all.
Yeah, thank you so much. I think thank you so much. But we still have the post test to be taken by all the participants. We still have 188 people there. So I think
Yes.
request team ICOG to please share the link for the test.
So can we
Yeah.
leave, Dr. Bhagya, or we have to sit through the
Yeah.
test?
Thank you so much. Thank you so much, Dr. Chitratara,
Okay.
Dr. Nisha, and all my esteemed faculty.
Thank you, madam.
So I think in a minute we will be sharing the link in the chat box as well as the QR code on the screen. So I think you can use any of them and answer the questions fast. So I think they have been very mindful. I think all of them will answer it 100% correct.
Ma'am, just
So
one comment, ma'am. It's a very,
Yeah.
very well put together program. Congratulations, ma'am. Well done. Useful program.
Thank you. I think the credit all goes to Dr. Usha. So she has done all hard work. So I am only taking the credit. Thank you so much.
Dr. Bhagya is always like that. She
Always shares the credit, Dr. Bhagya ma'am. She always shares the credit with colleagues.
No. She has really done. Usha has done.
No,
really
Usha
hard.
has done it. Yes, of course. Thank you,
I know she has
madam.
contacted
Thank you, Usha.
the
Yes, contacted
program.
me.
Maybe I've helped her a little bit. But I think over to all of you participants, please start answering the questions fast. So once that's done, then we will actually sharing the answers.
Okay.
And they have to score 50% marks to get the ICOG certificate.
Yeah.
So I think and hope that they have been mindful throughout the talk, but the talks were really very interesting. Very, very interesting. So I think the best of minds have actually worked for all the talks. Thank you. I think so
Thank you,
much.
madam.
I think
Yeah.
Thank you, ma'am.
faculty
Thank
can
you.
leave because you all are so busy people in spite of everything you have joined. So thank you so much.
Thank you. Thank you. Good night.
Thank you so much, Dr. Chitra. Yeah, thank you,
Okay.
Ambu. So how much time do we have for the questions?
It's written 15 minutes, ma'am.
Okay, that may be a little long time because they just have to click on what they know. Okay. So yeah, we have a stopwatch running. So I think 13 minutes are there. So let's wait and see what's happening.
We can leave, isn't it, Dr. Bhagya?
Dr. Chitra, yes?
Can we? Yeah, okay.
Yeah, you also can answer. Everyone can answer.
hello. Namaste. Phone call. ଟିକେ ଫ୍ରି ହେଇଯାରେ ଯୋଉଟା ଆମର ଗୋଟେ ସେମିନାର ତ ସତ ଟିକେ ଅନଲାଇନ ସେମିନାର ହଉ
I think very smart people. So many of them have done and already logged out also. Yeah. So I think Team ICOG, be ready with the answers. So immediately at the end of 1 minute 34 seconds, please share the answers. Yeah, I think Usha, you can discuss the answers.
Okay, I'll start with question number 1. The preferred adjuvant chemotherapy regimen for optimally debulked stage 3 epithelial ovarian cancer is, the answer is A, carboplatin plus paclitaxel. Question number 2, which of the following patients with epithelial ovarian cancer does not require adjuvant chemotherapy? The answer is A, stage 1A, grade 1 serous carcinoma. Question number 3, recurrent ovarian cancer is defined as, the answer is option B, cancer recurring after a period of complete response. Question number 4, which imaging modality is most commonly used for detecting recurrence? The answer is option C, CT scan. Can you move a little bit? Yeah. Question number 5, which imaging modality is recommended as the first line tool for adnexal mass evaluation? The answer is transvaginal ultrasound. Question number 6, optimal staging for stage 1 or 2 ovarian cancer, that is early ovarian cancer, includes? The answer is, can you move a little bit? Total abdominal hysterectomy, option D, total abdominal hysterectomy, bilateral adnectomy, omentectomy, pelvic and rectoperitoneal lymph node dissection up to the level of renal vessels. Question number 7, mucinous ovarian tumors are usually, the answer is option C, unilateral. Question number 8, which is the most common ovarian cancer seen in adolescents? Answer is option B, germ cell tumor. Move a little bit. Question number 9, in a patient with advanced germ cell tumor ovary, which among the following is true? The answer is option A, preservation of uterus and at least part of one ovary should be considered for fertility preservation. Question number 10, adjuvant treatment of properly staged immature teratoma stage 1A grade 1 is as follows. Answer is option C, active surveillance. Question number 11, ultrasound features. Which sonographic feature is most suspicious for malignancy? The answer is solid component with central vascularity is most suspicious for malignancy. Question number 12, regarding sex cord stromal tumor, all are true except. Answer is option number D, none of the above. Question 13, which tumor marker is most helpful in differentiating mucinous ovarian tumors from other epithelial tumors? Answer is option B, CA 19.9. Question number 14. A 48-year-old perimenopausal woman presents with lower abdominal discomfort. Ultrasound shows a 7 centimeter multiloculated cyst with papillary projections and moderate ascites. CA125 is 680 and HE4 is 210. What are the most appropriate next step? Answer is option B, calculate RMI and plan referral to gynec-oncology unit because it is most probably a ovarian cancer case. Question 15. Which of the following is true regarding the RMI, risk of malignancy index? Answer is option A. It uses ultrasound score CA125 and menopausal status. Question 16. Referral to a gynecologic oncologist is indicated when? The answer is option 3. Imaging or risk model suggesting malignancy. Question 17. Which of the following common conditions most closely mimic ovarian cancer with ascites and raised CA125? Answer is option B, peritoneal tuberculosis. Question number 18. The following statements are true about minimally invasive surgery in management of early ovarian cancer? The answer is option 5. Both 1 and 2 are true. Question 19. A 52-year-old woman reports a new onset bloating, early satiety, and pelvic discomfort occurring more than 12 times per month for the past 6 weeks, according to current guideline principles. What is the most appropriate next step? Answer is option B, order CA-125 and ultrasound. Question 20. Which symptom cluster is most strongly associated with ovarian cancer according to validated symptom index research? Answer is option B, bloating, abdominal pain, early satiety. That's all.
Yeah, I think thank you so much. So there are little queries in this one.
Question 18
Someone
appears
has
different here.
okay, different means it did not have the D, I think, what I understand. But that's okay because the answer is B. So anyway, so thank you very, very much. I think is Dr. Sarita there? Yeah, I think there's a comment from Chellama. So, sir has actually commented, Chelapan sir, that it should be simpler. But sir, can you unmute and speak?
Madam, no, it's not I'm not talking of the question answers. They were good
Yeah.
up to the
No,
level of an average.
I
No, my
understand
my
about the
point is,
level of
now
the.
let me see, madam, with the due respects to
Yes,
all
sir.
the
Yes, sir.
speakers.
No problem.
See,
No problem.
we
Yes.
are 70,000 Foxians. We
Yes,
attend this
yes.
ICOG lecture. We attend this ICOG lecture in various stages of life. Some are postgraduate, some are almost retiring physicians, clinicians, some are age practitioners. So the
Yes, sir.
idea is that when these ICOG, especially a platform like ICOG or Foxy, conducts a certificate course, the point should be at the end of each 10 or 12 minutes that you have decided, that is the policy of the ICOG, right? So at the end of 12 minutes, the average Foxian should know what are the take home messages from each lecture. Now, if you see, most apart from 2 or 3 speakers, most of the speakers they were having lectures. I mean, the slides were so full of data. Now, you
Okay.
just imagine,
Okay.
even a specialist of the oncology category cannot grasp all the matter in such slides. So the slides
Yeah,
should be
yeah, yeah.
made simpler. Okay, you have projected that slides, but at least that slide should not be at all projected because it distracts the average Foxian. That's what I'm trying to say. So, for
Sure,
example,
sure.
there are
We'll
so
take it.
many studies, 20
Well,
studies highlighted. So instead of saying there are more than 20 studies, only the take-home point from these studies is this. So what
yeah,
happens is
yeah.
everybody
Understand.
goes home satisfied. Okay, that the lectures have given us some, what you call it, impact factor for our routine practice. The idea is the ICOG lecture should increase the impact factor in our routine practice. That should be the idea.
Yes, sir.
Anyway,
Yes, sir.
madam, it's a
Thank you,
very good
sir.
effort. It's a very good effort. And I am seeing that the quality of the lectures are improving over the past 2 years. I'm sincerely attending each and every ICOG certificate course. And compared to the previous year's ONCO session, this was very good because most of the speakers almost restricted to that 10, 12 minutes, apart from few. And this was definitely better than last year's. Thank you. Thank you so much for allowing me to comment.
Thank you so much, sir. We'll remember what all you have given told. So I think from next time we'll actually talk personally to the speakers and see that the slides are made more simpler. Thank you, sir, so much for your input. So I think thank you, ICOG, and all the participants, all my respected faculty. Thank you, Usha, and all my HPGIC colleagues. So thank you so much. I think is Nilima around? Nilima, are you there? So maybe not. So thank you so much, Shreya, also for actually this for you only for your immaculate coordination. I think we were able to finish it in time. We are just 30 minutes beyond time. So thank you so much, all of you. So I think we can end the meeting and log. Thank you so much.